তুমি একটু ইয়ারফোনটা লাগিয়ে নাও।
স্যার ইয়ারফোন লাগানো,
ইয়ারফোনটা লাগিয়ে নাও। আর যতক্ষণ সরোদা তুমি মিউট করে রেখে তারপরে তুমি
We are live now, sir.
So restart.
Sir, you can start now. Sir,
Can we start now?
Yes, sir.
So good morning, good afternoon and good evening to all. Greetings from Indian Society for Adult Immunization. On the occasion of World Immunization Week, we are glad to organize our very first virtual World Congress on Adult Immunization on 23rd and 24th of April 2022. Our conference will be the first of its kind to revolve essentially around the topic of adult immunization, its history, benefits, relevance, allied medicine and controversies surrounding it. The theme of the symposium is Roll Up Your Sleeve for Vaccination to Combat Microorganism Invasion. The program will feature scientific sessions, panel discussion, lectures by the renowned clinicians, eminent public health professionals, scientists and doctors from different specialties around the world. So, we are now requesting Dr. Saurabh Kole sir, who is founder president of Indian Society of Adult Immunization. Sir, please start the program.
First of all, let me welcome you all. Sorry for the delay. And I think that in every conference, first of all, we go for the Saraswati Vandana. And we have with us Dr. Muruganathan. He is always an inspiration to us, always guided us. We have with us Dr. Amitabh Nandi. He is a renowned virologist, internationally famed, and everybody knows him. So we have with us Dr. Pasteur, who is an active member of the society and he is the organizing secretary. And we are going to start our inauguration program. So play the Saraswati Vandana.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्। या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहां हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Dr. Kole, please.
Now, I would request Dr. Muruganathan to say a few words.
Thank you, Dr. Kole, Dr. Parsadi Karmakar, and all the learned dignitaries. I'm really delighted to be there in your inauguration. As I told you, I am on my way to Bangalore, where I'll catch my flight to US. I am going to get my master's degree in ACP. So I'm going to US to get my convocation fellow mastership. But anyway, I'm very happy the persistent persistent work done by the Karmakar and Kole to promote adult immunization. In fact, it was my brainchild, and only we three were discussing as how we should start. Because I am in South, they have not included me probably as a organizing committee or in the society. But anyway, I'm very happy. This is the second time they are organizing, and I am there. See, one thing about adult immunization, even though we talk so much, people listen and clap and go. They don't seriously take this as a very important field. So my idea is, not only to talk, to make it like a, what comes out of this program. Suppose if there are 100 people who have attended this program, I want all the 100 to start adult immunization clinic in their hospital, in their clinic. Because, if everyone starts only, we can cover our 130 crores people. And the awareness about adult immunization is not that good even among the physicians, leave alone the public. So I'm happy. You should have a lot of programs, but the program with, some outcomes. See, what I did, as I said last time, when you conduct a program, you ask somebody who is sponsoring, get that X number of immunization like TDAP, give it to every participant before they leave the hall. So that, this project will be very successful. So doing is knowing. Knowing is not doing. So when you're doing only, you will know. Suppose if everybody knows that they have to take TDAP injection, they know its importance. Like that, every physician must have a protocol in place in their clinic to put that in their outside chamber. And you should have a regional language adult immunization material, so that, patients also can take over. Even in those days, even before the science is developed, we always say prevention is better than cure. For prevention, they always say good air, good light, good food, good hygiene, good habits. So that's how the prevention played a very important role in those days also. Then the WHO says after the clean water, immunization is the number one to prevent any disease. So COVID came, nobody was aware about the importance of vaccination. So thanks to COVID, at least some good things have happened for COVID. Again, the important vaccination in any disease, in my opinion, is not only immunization or injection, it is education. Education, education, education in regional language. Be it hypertension, be it diabetes, be it any infection disease. If you have a proper education about that particular disease, and if you create an awareness, and if you spread the knowledge to every person, then it becomes a real vaccine. So in my opinion, first vaccination is education, and also second is about clean habits and also clean water, and then knowledge about every vaccine. And I think you are organizing this program. I'm very happy, but make sure at the end of the day you get a feedback form. See how many people have understood. See how many people are going to implement. Tell me how many vaccination clinics we have started. So to start a vaccination clinic, there are some certain basic requirements, which I have also shared in my book on adult immunization. So you start a vaccination clinic. It's also good for the physician to start a vaccination clinic so that you get more patients and people are aware. Take, for example, pediatricians. All pediatricians have a very good vaccination center. So like that, we must start. And I congratulate Dr. Pole and Dr. Karmakar and all the organization committee members to continue. But what I want is some effect out of this workshop or the webinar or the meeting. So with this, I once again very happy to inaugurate this program, and I'll be very happy to participate in person next time. Please take my time at least 1 month earlier so that I can come and see all of you and impress you. And also please have a real good outcome out of this. Thank you very much. Take care. Stay safe. Now COVID in Tamil Nadu, we have got at least now about 100 to 150 cases. So people are now worried. They are now saying mask is compulsory, and all good habits you should continue. Thank you once again. Bye.
Thank you, sir, and wish you a very safe and happy journey to US.
Okay, sir. So
thanks, Doc.
So thank you, sir, for your excellent inspiration for us also. And without now, I would say something that whatever the thoughts so far we have from our society, we believe honestly that the vaccines are one of the greatest achievements of biomedical science and public health, and are created with adding good number of years to the life expectancy of the people in the last century. Now, obviously, people are also believing that the immunizations are necessary not just for the kids. Regardless of the age, people need immunizations to keep themselves healthier. And over the last few years, changing lifestyles, mortality rates involving infections in adults and elderly, and it's posed a burning threat to our critical care and health delivery system. Surprisingly, amongst the diseases, a good number of infections are preventable by available vaccines. With adulthood comes responsibility, including the need to protect ourselves and our loved ones. The preventive medicine will be an integral part of the critical care medicine near future. I strongly believe that the preventive medicine will also be an integral part to the critical care medicine. And it is noteworthy that in countries like UK, the NHS have made adult immunization mandatory in certain situations, even as early as 25 years ago. Making adults immunized serves two purposes. It prevents the occurrence of certain diseases, which although leads to critically ill patients and actually preventable, and prevention of those diseases leads to decrease the overall medical expenses associated with the diseases which would have otherwise incurred. This means that adult immunization simultaneously tackles decreasing the disease and alongside the decreasing the overall cost involved. So what I mean to say that if we go for the adult immunization, probably health budget of the state, health budget of the country will be also decreased. It is easy to say from this that mandating adult immunization has benefited not only the health and well-being of the general population, but also the section of the NHS responsible for the medical expenses of the individuals concerned. So this is one of the main points is ISI wishes to highlight here in our discussion. The ISI, Indian Society for Adult Immunization, was formed in 2013. We have participated in and organized multiple projects and awareness programs directed towards discussing the benefits of adult immunization so as to increase the overall awareness. On the occasion of World Immunization Week, we are glad to organize our first very World Congress on Adult Immunization, where faculties from the different parts of the world are going to participate. And the theme of this symposium is Roll Up Your Sleeve for Vaccination to Combat Microorganism Invasion. The program will feature scientific sessions, panel discussions, lectures by renowned clinicians, eminent public health experts, scientists and doctors from different specialties. And I am sure that we are going to have a good academic fest in for the next 2 days. And with these few words, I would expect that every participants who are here, they will earn a good knowledge after this conference. So thank you very much. Now I would request Dr. Pasteur to say a few words. Dr. Pasteur, unmute.
Yeah, thank you, Dr. Kole. Good evening, everybody. And it's a very, very pleasant moment for all of us who are organizing this World Congress, first ever World Congress on Adult Immunization, that ultimately we have been able to organize this conference. And probably many of you know, but many of you are not aware that we planned this physical conference on adult immunization in the year 2020 in the month of April. But you all know, due to lockdown and COVID pandemic menace, we had to postpone it. But ultimately today we have been able to organize ourselves to make it ultimately in this evening. So I'm really thankful to all the distinguished guests like Dr. Muruganathan, who is really one of the brainchilds of this adult immunizations program and to develop its awareness among ourselves. We are really still lacking so far adequate awareness regarding adult immunization is concerned, because all the time immunization, we all the time mean that it is for the children, but adults cannot be kept off the hook from immunization. So that is to be kept in mind. And apart from Dr. Muruganathan, Dr. Kole is always here to inspire us for holding this program. Dr. B. Chandrasekhar from South India, our another sir, Dr. Amitabh Nandi, they all are here, and many other distinguished delegates as well as distinguished dignitaries are present over here to make the program successful. So I am also very much thankful to Dr. Satabdi, Dr. Devdatta and Dr. Ibu Vasu for working hard for last few weeks to make it ultimately possible. So I am also thankful to Dr. Shonal Shah, Ms. Shonal Shah and Mr. Jignesh for their hard work also to make this program possible. So I am thankful with folded hand to each and every person who has put their contribution. Without their contribution, this should not be possible for us to make this mega event with academic fees for 2 days, today and tomorrow. So with these few words, I hand over the mic to our chairperson, Dr. Saurabh Kole and Dr. Shatabdi Ray. Over to Dr. Shatabdi Ray or Dr. Saurabh Kole. Dr. Shatabdi. Dr. Shatabdi. Please
We are going to start our first session. Our first speaker is none other than Professor Amitabh Nandi, and from the very beginning of this conference, I got inspirations and all the time some sort of suggestions to make this conference a success. And Professor Amitabh Nandi, he was the formerly professor and head of the protozoology, Calcutta School of Tropical Medicine, former chairman division of parasitology, Calcutta School of Tropical Medicine, former in charge of malaria clinic and in charge of Kalajar clinic, Calcutta School of Tropical Medicine. Actually, he is the teacher of teachers, and presently he is the director, Center of Tropical Medicine and Parasitology, and a consultant on tropical and infectious diseases. He has done a lot of clinical trials and animal experimentation of parasitic diseases, mainly of malaria, Listeria, Kalajar, intestinal parasites, etc. And he has membership to advisor to WHO, advisor Government of India, advisor Indian Council of Medical Research, advisor National Vector-Borne Diseases, and he had a lot of publication of papers and books and more than 100 in international and national journals. So with these few words, I would request Dr. Amitabh Nandi to start his deliberation. Dr. Amitabh Nandi, please.
Sir, you need to unmute the mic.
Yeah.
And
Hello.
Requesting
Am I
you
audible
to,
now?
Audible, sir. Requesting you to put the slides on a slideshow mode.
Yeah.
Over to you, sir.
Thank you. Hello. Good evening, ladies and gentlemen. I'm happy that I am a participant in this very important conference I have been looking for. I had a good amount of discussion with Dr. Kole, and I have been in touch with Dr. Kole regularly. Anyway, I was asked by Dr. Kole to say something about the historical aspect of vaccine development. Let me begin with a statement to which perhaps I believe none of you will disagree, that vaccination and variolation are almost synonymous. Fundamentally, the road through which the present day vaccine came over could be divided into two phases. Number one, the noxus stage with miasmic theory dated back to thousands of years, where people did not know the existence of microbes and their etiological role in causing diseases, and yet it was surprising that they pursued developing procedure for epidemic control in the form of variolation. And number two, the next stage with germ theory, wherein one after another revolutionary discoveries were made to incriminate microbe as causative agent for infectious diseases, opening up a plethora of scientific areas, all interlinked to bring out and establish newer disciplines in medical vis-a-vis biological science like microbiology, immunology, molecular biology, etc. But it was amazing to notice thousands of years back how people could conceive the idea of controlling disease like smallpox with transferring some of the clinical material from a diseased person to a prospective candidate. And that is the great event of variolation, which shall be considered as mankind's first footstep into the arena of vaccination. Needless to mention that the root of the history of vaccine can be traced back to the initial era of smallpox. And that is the dawn of vaccination through variolation. While clinical evidence of the disease could be found in the mummy of Ramesses V, dating from 1145 BC, it is believed that smallpox actually emerged in human population thousands of years ago. As per available literature, the actual immunoprophylaxis started with variolation more or less around 1000 years back, and hence any discussion on human vaccination without discussing variolation would be perhaps incomplete. Records of this procedure date back to about 1000 AD in China, wherein the material from scabs stored for approximately 1 month or more in the winter season, grinding in a ratio of 4:1 with extracts of Eulalia grandiflora, a plant, used to be inoculated intranasally on mucosa, whereas in Indian subcontinent, Southwest Asia, North Africa, during 16th and 17th century, the variolation was parenteral. The variolation reached England in 1698 to 1700. References available credit Lady Mary Wortley Montagu, who suffered from smallpox in 1715, of introducing a practice of variolation in Britain. In 1717, Mary had her 6-year son variolated under the supervision of a surgeon, Charles Maitland. Within next 4 to 5 years, when London was razed by smallpox epidemic, the practice of variolation gradually became more and more popular in England. During the last decade in 18th century, smallpox became rampant in Europe. Despite the increasing use of variolation, interestingly, it was observed that milkmaids were selectively spared the ravages of smallpox and somehow related to the mild pox infection that they often acquired from the cows they milked. Although several educated men and physicians during the period from 1765 to 1791 acknowledged this association, it was Edward Jenner who capitalized the Q, hypothesized, and undertook to rigorously test it in 1796 to prove the putative protective effect of the prior cowpox infection against wild smallpox by actively immunizing an 8-year-old boy with cowpox and then challenging him with a wild smallpox exudate. It is not until that experiment with cowpox virus in 1796-97 by Edward Jenner to develop an acquired immunity did the science of vaccination officially take off, wherein the Latin word vacca, meaning cow, was justifiably used to name it as vaccine. So that was the genesis of the word vaccine and vaccination. That was also the first logical experimental evidence of a non-human virus providing protective and disease-modifying response in man to a deadly human virus. This was followed by the same procedure in other children. Jenner had the foresight to publish his results But being refused by the Royal Society, he self-published a booklet in the year 1798. It is fitting that smallpox became the first communicable disease actively eradicated. However, an enigma that still remained unresolved was the origin of genus vaccine virus. Whatever may be its origin, whether it is vaccinia, but vaccinia is a separate species within the orthopox virus, genetically distinct from both cowpox as well as smallpox. Possibilities are threefold about its origin: a hybrid of cowpox and smallpox, or it may be a derivative of the cowpox virus, or a descendant of a virus that no longer exists in nature. As per the records in America, variolation was introduced in 900. Let me tell you at this point, at that time, somehow there were maybe the strain, because of the strain variation or antigenic variation, the clinical presentation was one of very severe type and the other one was the milder type. The severe one was called the variola major and the milder type was variola minor. Now, epidemics of variola major continued to occur at intervals until 1927, and most 20th century cases of smallpox in United States was caused by variola minor at that time. The origin of the strain, however, was not clearly elucidated. An attempt on compulsory variolation, although was upheld by the US Supreme Court, anti-vaccinationist sentiment and apathy towards compulsory vaccination prevailed in many states and actually prohibited compulsory vaccination. In the meantime, incidence of smallpox and its case fatality rate declined gradually. Between 1932 and 1939, the case number was 5,000 and 15,000, and the report, the death number was 21 and 52 respectively. Although last case occurred in 1949, the childhood vaccination in the United States continued till 1972 to prevent the imported cases. The preceding discussion was made to emphasize what we have learned out of this discussion. Now, there are twofold. I would like to put it in this way. Number one, that in-depth observation, as was made by Jenner, of clinical and epidemiological events and very logical interpretation might result in wonderful discoveries. And number two, even in the absence of immunology as a science, our predecessors could point towards cross-protective nature of diseases, particularly microbes, whether it is a species specific or variant or strain specific, and also to a process of attenuation. So it's surprising, even at that time, there was this type of knowledge prevailed. Now, the next phase started roughly, say, in the second half of the 19th century, with the beginning of discovery of several microorganisms which were causing the infectious diseases. This phase would be termed as a germ theory phase, as was marked by significant discoveries related to etiological role of microbes for communicable and infectious diseases, which gradually replaced the noxious miasmic theory. Demonstration of causative microbes by microscopy, their isolation, and animal experimentation were the key advances related to germ theory in the second half of 19th century. The notable names were Robert Koch, 1843 to 1910, and Louis Pasteur, 1822 to 1895, made a series of game-changing contributions through their many key observations and experiments in both agriculture as well as human infectious diseases. To name a few very important postulations, one of which is Koch's postulate, and the second was done by isolation of the Bacillus anthracis as a cause of anthrax. At that time, anthrax was raging all around. Work towards vaccination was modernized then by Louis Pasteur, with accidentally finding attenuated chicken cholera cultures efficacy in human cholera. Apart from the anthrax vaccine, Pasteur's work on rabies virus is his more well-known work, which was introduced for human testing in the year 1885. In the 19th century, Pasteur and Koch certainly knew that microbes were the cause of infectious diseases, and that a weakened form of the microbe or the vaccines could create a protective state in the recipient, but they had no specific knowledge about the immune system and immune responses. Once into the 20th century, the progress of vaccine development blossomed, and now there are multiple methods being developed using live attenuated, inactivated or dead vaccine organism, protein, polysaccharide, or even genetically engineered ones. In the early 20th century, passive immunization was developed as a therapy for infectious diseases. In the year 1900, von Behring used horse serum from the immune horses to treat diphtheria, for which he was awarded the very first Nobel Prize in Physiology and Medicine. During the second half of 19th century, scientists were discovering immune systems defense mechanism by that time. The 20th century was full of multi-directional development in vaccinology, and by the 21st century, it became multidisciplinary in nature to incorporate microbiology, immunology, medicine, epidemiology, statistics, policy, manufacturing, biotechnology, molecular biology, genetics, public health, and last but not the least is the ethical side. In 1924, Ramon developed the method of chemical inactivation of bacterial toxins with formaldehyde and heat to produce a toxoid out of the bacterial toxin. Similarly, in 1951, the Nobel Prize in Physiology and Medicine went to Max Thiele, who attenuated yellow fever virus through serial passage in mice to develop highly effective live attenuated yellow fever vaccine. The discoveries thus continued, and now we are fully equipped with various aspects of and various technologies of vaccine development. The decades following World War II have been described as a golden age for vaccinology. However, during this period, several other areas was brought to the field of vaccine development, especially the areas which was previously not considered to be incorporated in the development of vaccine and its manufacture and implementation. But gradually people became aware about other issues, and areas like...
Sir, we have lost 15 minutes, sir.
Okay. During this period, several other areas was brought to the field of vaccine development, especially conflict of interest, the initial clinical evaluation in the form of phase 1 and phase 2 clinical trial for safety, immunogenicity, and preliminary efficacy. While the long-term evaluation of vaccine efficacy included phase 3 and phase 4 trials. The other important issues having tremendous impact on any vaccine development includes informed consent, inclusion or eligibility criteria, randomization, element of bias, selection, identification of element of bias, the target population, and post-marketing monitoring and surveillance. I have next few slides to show you year-wise how the vaccines, several vaccines were developed. This was the first vaccine developed in 1796 by Edward Jenner against smallpox, and there is a very long list. This all happened in 19th century, but thereafter you will notice in 20th century we were flooded with developing vaccines against several of the diseases. Now the list continues in 20th century. And finally, the 21st century, in the year 2000, the first pneumococcal conjugate vaccine was developed. In 2003, first nasal influenza vaccine approved in the US. In 2003, first vaccine for Argentine hemorrhagic fever was developed. 2006, first vaccine for human papillomavirus, which is a cause of cervical cancer, was developed. And in 2006, first herpes zoster vaccine was developed. 2012, hepatitis, 2012 again influenza vaccine, 13 enterovirus, hand, foot and mouth disease, in 15 malaria vaccine, in 2015 dengue fever vaccine, in 2019 the Ebola vaccine was approved, and 2020 the current COVID vaccine was developed. So with all these list of vaccines developed during such a long period of time from 1796 to present day, I conclude here, thanking you all.
Thank you, sir, for your excellent deliberation. And delegates are requested, if you have any questions, please send to the chat box. At the end of the session, we will take care of all the questions. Now I would request Professor V. Chandrasekhar. He is the chairman of API of Telangana State, and he is a professor of medicine, Kaktiya Medical College, Warangal. He is the medical superintendent, additional director, Mahatma Gandhi Memorial Hospital. He was the former principal of Kaktiya Medical College, and he is a postgraduate teacher in medicine for last 24 years. And he addressed national and international forums, regular faculty in EPICON, RSSDI, ACPCON, IMA. He published many articles, papers in national and international journals. He contributed chapters for Medicine Update and monograms. He will speak on adult immunizations, background, challenges and possibilities. It's a very important topic. Professor V. Chandrasekhar, please.
Good evening, sir. Good evening, all the audiences. At the outset, I thank Dr. Saurabh Kale, sir, and my friend Dr. Partha Karmakar, because he is insisting me to have some presence in this prestigious International Society of Adult Immunization chapter. So that is how I am here. So without wasting much time, I will go into the topic. So let me share my screen, sir, first. Sir, is it visible, sir?
Yes, it is visible. Please make it full screen.
Yeah, I made it to full screen, sir.
Yeah, absolutely visible.
So this is the topic I'm talking, adult immunization, background, challenges and possibilities, and how we can overcome. So it is a very great move, sir, by the International Society, and this kind of CMEs, awareness programs from time to time and very repeatedly has to be done, sir. So why adult immunization? Because by traditionally we are immunizing, vaccinating only the children's under the coverage of universal immunization program. But there is why this need for adults to be immunized. So it is very well known that there is a burden of adult vaccination preventable diseases, and there is some issues, the vaccine effectiveness in adults, and adult immunization coverages rates are very, very meager, and the challenges and other things I'll mention, and the ramifications of failing to vaccinate the adult populations. So these are the some of the issues I'll discuss in my coming slides, sir. So coming to the background of our own India, India is the second most populous country with 140 crore people. So that is amounting for 18% of the world population.
Sir, please make the slides full screen, sir, please.
So I think I made a full screen, just a minute, sir. So is it full screen now?
No, sir.
No, you will get.
Sir, is it moving full
At the
screen?
bottom. Mr. Jignesh, please help him. Please come to the bottom.
Sir,
Yeah,
so I would
Sir, please.
request you to unshare the slides and reshare it so that
Okay.
the glitch will be taken care.
That may be the reason. Okay, I stopped sharing, and again I am sharing, and these are my slide set. So I am again sharing, and this has come like this. So now I have to full screen. Okay. So now it is full screen.
No, sir.
So I don't know, there is some problem.
Sir, in the please unshare, and in the share button, share screen instead of share slides. Okay.
Okay. So I have to
Please
go back.
Is unshare first.
Yes. Stop sharing.
Then
Yeah.
share screen.
Share.
Green
just
button.
green button. Yeah.
Share
Yeah.
screen.
Share screen. That option.
At the bottom.
Yes. Then I have to PowerPoint show.
No, not PowerPoint, sir. In the upper part, there is a option for share screen. Please share
Yeah.
screen.
Yes, sir. Yes. This I have to share. Now it is?
Yes, it's fine.
Yeah?
Yes.
Yeah.
Okay, sir. So is it moving? Yeah. So sorry for the technical issues. So we know that India is the second most populous country, and 63 million people are pushed to the poverty by the health expenses each year. So that means the disease has its own ramifications. Even some people are survived, they are living with the morbidity, and they became poor also. And household health costs also increased from 15% in 2004 and 5 to 18% in 11 and 12. So of course, these are the little bit old data. But what we are here is communicable diseases, maternal diseases, neonatal diseases, and nutritional diseases. So these are accounted for almost 30% of disability adjusted life years, and they are responsible for up to 30% of deaths depending upon the age group. This is the biggest challenge. So where we can overcome by uplifting the adult immunization. So risk of the infection is also increased these days. So probably the antibiotic resistance and antibiotic use or abuse, so whatever it may be, so that is resulting in antibiotic resistance. And there is a mutation of the antimicrobes, and globalization and travel, because somewhere in the some part of the globe some infection is there, so very next day it may be coming to us. And these so-called vaccine preventable diseases affects the adults worldwide, and they are responsible for high morbidity, mortality, and economic burden. Unvaccinated adults can spread disease to the unimmunized infants, because say for example pertussis has been given full doses during the childhood, but so it may cause after that immunity waned after full vaccination also. So unvaccinated adults can be there is a spread of the infection. So improving the adult vaccination coverage could have a positive consequences that we all know. So coming to the India, lack of adult immunization and lack of understanding the importance of improving the coverages of this vaccination is the paramount. So these are the multiple factors for considering the healthy lifestyle. So there is a triad of healthy food and having the physical activity, and there is a life course immunization. The name itself is very, very important, because immunization in India means immunization only for the infants and childs. So the no age is bar for taking immunization. So that is the reason why the life course immunization is put here under the bottom of this pyramid. So of course other factors are all there. So this is how we have to maintain the healthy lifestyle. So in this, so where are we? All these important factors are being often neglected, and our healthcare system is now only symptom based, diagnosis based, and treatment hospitalization based. So we have to come that part out of that part, and we have to focus on this. This is the high time. And I appreciate the organizers, because you have picked up to spread the information about this life course immunization. So, and coming to, so why do we vaccinate? We know that it is not only for the optimizing the health, and it is protecting the persons who has taken the vaccination, but at the same time, it is preventing the person from the spreading infection. So they are vaccinated persons are the building blocks preventing infection from one person to, and that is breaking the infection chain. So it is a twofold mechanism. One, it saves the person and it saves the community also. So for that is the reason, if no one is safe till everyone is safe or everyone is vaccinated. And one more thing is that WHO categorically says that, so immunization beyond the infancy of 18 months of a baby is the global priority, because these aging population more than 50 years are increasing, and they are amount for the 27% of the global population by 2036. And coming to the India, so we are the youngest population between 20 to 40, but the older individuals more than 50 years are going to increase in coming days. Right now, it is about 19% of elderly population, but this is going to increase to 24% in coming days. So because you have to catch hold of these young adults to give immunization, not that you have to directly go and give the immunization at the elderly, because there are problems when you want to vaccinate, that vaccination and immune conversion may be also difficult. So catch hold yet when they are young, so that this thing. And coming to the India, these vaccine preventable diseases are 2 to 3.4 times higher than any other country in the world. So one more thing is that age is the criteria. We have picked up very well that the infants and young children for vaccination, almost 100% universal immunization is covering, but our risk is the increased age, because the extremes of age is the risk for developing the communicable diseases. But here my point is that increasing the age also will have increasing in the comorbidities. Say for example, hypertension will increase in elderly population, cardiovascular diseases increase, and diabetes, which itself is an immunodeficiency condition, chronic lung disease, COPD, and bone and joint diseases. Particularly these four, which are increased by 3 to 4 times these days till 65 and 75. So these are the comorbidities, so which also an indication to have the vaccination. So adults are susceptible for the outbreaks of the vaccine prevented indications. So because lack of the adult immunization is the very important reason, and the waning immunity by over the time, so the childhood immunity will not persist for the throughout the lifetime. So particularly this tetanus, pertussis, diphtheria, definitely after 20 years need a regular booster doses. And if you further wait for so many other things, so because age related factors, so-called the immunosenescence will decline. So you cannot wait till he cannot catch up the immune after the successful vaccination also. And the more important, in the previous speakers are told, because these epidemiological shift. So if the young people are children are protected with immunization, so that microorganisms will try to concentrate on the unimmune persons. So this epidemiological shift is possible. So this is a very great example in the COVID era also, because in the COVID era, we have taken the immunization priorities to the aged person. And we have taken the priorities of immunization with comorbid persons and leaving the children. And this is a reverse epidemiological shift. So that is the reason why if further waves comes in India, so the children are the most common. So this is a very good example, because as the Muruganathan sir told that our priorities have been very much identified. COVID is a real medical teacher to change our thinking. So coming to the a vaccine effectiveness, it all depends upon the vaccine type. So that means a research also should be improving. So not the stereotype. So some genetic material, so that whether it will, how much it is seroconverse, and not always to prevent the infection itself. We have to see the outcome also, because the COVID vaccination, so not only decrease the infections as in the third wave, but it has reduced the outcomes. The mortality has reduced, morbidity has reduced. So these outcome parameters also very important. And so the outcome should, whether prevention of death, prevention of the hospitalization. So prevention of hospitalization is the cost saving. So whenever you are thinking about giving vaccination, the cost benefit ratio also you have to take. And here, by reducing the visit to the doctors and emergency rooms, so you are saving some resources also, and the disease symptoms are also minimized. So this all depends upon the population also. So keeping this in the mind, there is some, because the immunity will wanes through the ages, because the children are less immune and elderly are less immune, but adults age are appropriate immune, but they are they will soon succumb to the immunosenescence because of other factors, because the young age people are catching with the non-communicable diseases like COPD, diabetes, hypertension. So these are compromising the immunocompetency in even so-called adult age groups also. For this reason, so you cannot take any chance. And moreover, if you want to immunize the elderly person, so they may not be the enough seroconversions. So catch them at the appropriate age so that their immunity will still into their age. So these are the mechanisms for immunosenescence. I don't want to go into this thing. And because so there is a epidemics, pandemics, we all know the latest pandemic, the COVID-19, we know. So probably there may be the reasons that so we are not having the annual influenza virus vaccination. So that may be also contributing. So I don't want to go into, because these epidemics and pandemics will come after the due course of time. However, we are vaccinating also, because it is, we are living in the nature, and microbiomes also living symbiotically. So when we are not taking enough care, so they will come like a wave and succumb us. And there are many examples here. So because many diseases in adults often misdiagnosed, underreported. So for example, the whooping cough, we think that it is a childhood disease, but it is not in the adults. Adults, it may present in a different manifestation. So you see the study incidence will be like 78 times and reported incidence is less. So unless
Dr. Chandrasekhar,
sir.
just a gentle reminder.
Yeah. Okay, sir. So annual incidence is also reported incidence is lesser than unless you do look for it. And here is the thing, that estimated duration of immunity. So for the natural infection, it is 4 to 12 years. Even without natural infection also, if you are going for vaccination, 4 to 6 years. And these VPDs are having serious impact in the form of length and severity of the disease, so that the costs and complications and quality of life and mortality also. And influenza is one which is an example which will show that influenza associated deaths are 90%. So the children aged 2 to 5 years are at risk of the influenza. So, but once they are not taking the annual incidence, so it will lead to other complications also, not exactly that influenza of 4 days. So this, while vaccination against influenza does not prevent the COVID-19 also, it is recommended for because of other benefits. So the vaccination is also, my point is that vaccination also having the pleiotropic effects, and every global bodies like WHO, GINA, and Association of Physicians of India has recommended, for example, the diabetes, hypertension, HIV, AIDS, asthma and COPD, and even chronic heart and lung disease also. Because a patient is taking a influenza vaccine can have a less MI, and if a patient is taking zoster vaccine have a less chances of developing CVA. So the influenza vaccine in COPD will reduce 38% in the mortality. So like this, there are even cardiovascular patients. So 25% reduction in the risk of hospitalization by cardiac just by taking the influenza. So all these benefit needs to be a diabetes and influenza. So this is one example I am taking. So this much is very difficult. So coming to the current challenges, so there is a burden of the VPDs is increasing. So 26% of health science students are serologically susceptible for varicella. These are all examples. And so in one study from the Jodhpur, so here they have started the adult vaccination center, but the statistics, so they have given the post-exposure TT and anti-rabies. So the adult immunization means they are only for these two. But the very good examples for the prevention, yellow fever, hepatitis B, pneumococcal vaccine, typhoid, influenza. So there are very meager. Influenza is only 1% reported from that center. Yellow fever is far better, 15%. So it is not sufficient, and barriers, lack of surveillance, lack of national guidelines, even if the national guidelines are there, lack of awareness and lack of coordinated with vaccination programs. So treatment taking precedence over the prevention. So inviting the disease and going and admitting a tertiary care, but not interested in taking vaccine. Lack of provider recommendations also, cost sometimes, insurances and all. So these are all the barriers. So there is a potential solutions for these barriers. Though pilot studies to collect the data, to exactly note what is the VPD burden, multidisciplinary consensus to develop the national guidelines, introduce a coordinated adult immunization program, and incorporated vaccination checkups. More affordable brands should be coming. So cost is also a factor, and it should be included in the so many insurance schemes. And one must educate first healthcare professional. We ourselves should conduct the programs like this, so that we can promote the benefits and we can overcome the barriers. And for this lack of knowledge and recognition of the benefits and efficacy, so even general public also need to be this thing. So way forward is we have to create awareness, highlight the burden of VPDs, summarize the Indian adult vaccination recommendations, discuss for reasons for adult vaccination because the waning immunity, immunosenescence, and propose solution and steps to be taken. Implementation guidelines are there, but implementation is not happening at the ground, this thing. So coming to the sum up all these things. is already mentioned. It's only summary. So these are the recommendations for adult immunization schedule in 2000 level US. So you understand this age group. So 19 to 16, 27 to 49, and 60 to 64. So all these, this pneumococcal vaccine, PCV, and MMR vaccine, meningococcal, and all these things. So this is everywhere it is available, but the implementation is lacking. So coming to my conclusion of talk, if not addressed, the burden of the infectious disease is likely to have devastating effects. Awareness and public education of insufficient unless supported by with the recommendations. Efforts focus on the VPDs and collect their data. Stakeholders like vaccine producers, experts, policy makers, even government should make it say compulsory. Even that regulating bodies like NBH and Quality Council of India should promote all the hospitals before giving certification. This is a mandatory. And life course immunization, though just we are taking a birth and taking vaccination is not sufficient till we die. So better it is a life course. Immunization is for life course. Adult vaccination in India is negligible due to lack of not lack of guidelines, but lack of consistent guidelines. So improving the adult vaccination has advantages like reduces the burden of the disease, hospital admissions, health costs, and mortality rates, and moreover, improving the quality of life. So I'll conclude here. Thank you very much for giving this opportunity. Because of the limited time, I'm rushing through the slides. Thank you very much, sir.
Thank you very much, Dr. Chandrasekhar. Our next speaker is Dr. Pankaj Bhardwaj, and he is going to speak on a very important issue: adult immunization guidelines and practice. How can we bridge the gap? Actually, in our country, definitely guidelines from the Indian Society of Geriatric Medicine, API has also got some guidelines, and different societies, they all have some different guidelines also. So we'll have to think that how we can come to a conclusion and whether any national guideline can be done in near future. I'm sure from Dr. Pankaj Bhardwaj, we will definitely learn something. And he is the Dean Research Additional Professor Community and Family Medicine. He is a Nodal Officer Adult Vaccination Center, AIMS, Jodhpur. He is the Chief Editor of Indian Journal of Community Medicine. His training fellowship, Advanced Vaccinology course, and the FAMER Fellowship, Observership, ECDC Stockholm and ATTC Munich, Germany. Expert group member, different working groups on adult vaccination, One Health Consortium, UG Board, National Medical Commission, Committee for Establishing Public Health Schools in Rajasthan, and number of publications more than 150. Dr. Pankaj Bhardwaj, please.
Thank you, Professor Kole. Thank you so much for giving me this opportunity to speak. In the interest of time, what I will do is I'll be very brief. But at the same time, I would like to keep my video off in order to keep my bandwidth safe, because currently I'm actually struggling with a very weak internet. So what I will do for the next 5 or 7 minutes, I will try to be as brief as possible in the interest of time. So let me share my screen and kindly tell if my presentation is visible. So yeah, so if my slides are visible. Hello, am I audible, sir?
Yeah, very much visible and very much audible. Please continue.
Yeah, thank you so much, sir. Thank you so much. So at the outset, I would like to extend my heartfelt thanks to the organizers for giving me this opportunity to share my thoughts on this very important aspect of adult vaccination, which is a very important, I think, effort which is being taken from the organizers. I've been in contact with Dr. Riva and Dr. Devadatta, who've been in constant touch with me. So thank you so much for this opportunity. And thanks to my previous speaker, in particular, Dr. Chandrasekhar, for making my task a bit easier, because many things have already been covered by my earlier speaker. So what actually started at our place was, as Professor Chandrasekhar very rightly said, that in state of Rajasthan, we got this opportunity to start the first adult immunization center. And when we started this center a few years back, pre-COVID time, there were challenges. And we were trying to find out that what exactly is hampering in having these adult vaccination units in the country. And the biggest challenge which we found was that unfortunately there is no national level guidelines available for adult vaccination. I would like to put it on record that I'm not saying that the guidelines are not available. Guidelines are available. They are by different professional organizations. But as in pediatric units, we have Indian Academy of Pediatrics, or at the national level, it is from Ministry of Health, or what we call as WHO, UNICEF, which have been adopted well by rest of the country. These national level guidelines were still lacking, and they are still lacking currently also.
Excuse me, sir. This is
Yeah.
Sonal here, sir. I
Yes.
would request you, if possible, can we have your video, please?
Yeah, so Sonal, that's actually the issue, that my bandwidth is very weak. So
Okay.
in that case, yeah, that would be a challenge for me. And currently I'm also traveling. So I thought of keeping it off, if that's okay, because that's the biggest challenge for saving the bandwidth.
Okay, please continue.
No problem, sir. No problem.
Yeah, thank you, Sonal, for understanding. So now the guidelines and schedules, which we thought when we were making our own guidelines or standard operating procedures for our OPD, we could gather some of them. And as most of us know, who are already working in the adult immunization clinics, that the biggest guideline which we follow is ACIP guideline, which have been given by the CDC. And this advisory committee on immunization practices provide us the base for making all these immunization guidelines for our adult population. In India also, efforts have already been made in 2015 by the Society of Geriatrics, or Geriatric Society of India, where they have published guidelines for older individuals. And few efforts were also made by associations like Associations of Physicians of India, API, Indian Medical Associations, and also Indian Association in Occupational Health, in particular, where they talked about medical field people, be it nurses, paramed staff, or doctors, for having these guidelines. As Dr. Chandrasekhar was also showing this very important slide, because that was the base which we could find, which was actually talking in terms of age-wise, the guidelines which were actually starting from 19, as we know that till 19 we have the adolescent age group, and from 19 onwards we have the adult individuals. So if you can see that till 50, there is a kind of the need of these vaccines. So they are actually age-wise, where yellow color is showing that this is in each and every individual, no need of having any spatial condition. And that was in influenza. Most of the time it is in diphtheria, Tdap or TD, or MMR or varicella. So these were actually being shown very nicely, and very rightly they have mentioned that these are the number of vaccines which are required to be given to all healthy adults. So we need to understand this very important fact that these are for all healthy adults, where these yellow color is shown. And in all these purple color, actually these are some of the additional factors. They may be covering, they may be coming from the side of medical field due to their risky job, or maybe travelers, or maybe having some conditions like diabetes or any other condition where we need to put them. So this was the first guideline which we could find, that was age-wise. The next was definitely on some of the important condition, as Professor Chandrasekhar was also mentioning. And that was, for example, I've seen in my own OPD that when we have patients of asplenia, that may be because of multiple myeloma, or where the splenectomy is done, we got a regular referral from our surgeons, where they sent all these patients to us. The chronic renal failure patients, this is a very important part, where as a center of the dialysis or center for kidney transplants, AIIMS have a large number of patients who are actually on their renal diseases, and where we are getting a regular referrals from our surgeons, where we need to put them. HIV, and these were the spatial conditions or specific areas where these guidelines were provided, and that was provided exactly as I said from ACIP guideline of by CDC, or Center for Disease Control. Now, this I was talking about that I should not say that India is not having, or the people or the physicians in India are not serious about adult vaccination. They do have their guidelines, which have been published so far by the Associations of Physicians of India, where similar kind of guidelines have been seen and have been developed and released by these associations. That was also an important part which we could find out. For example, I would like to say in particular about the pneumococcal vaccine, because we all agree that PCV13 is now a part of the pediatric the immunization program. And now, because all children are getting Prevnar, so now this needs to be taken care very clearly, because these children will only get PPSV 23. But for people like us who are already been born years back, when PCV 13 was not a part of a regular immunization schedule in pediatric age group, we need both these vaccines for us. So this was a glimpse of what is being proposed by Indian Academy or Indian Association of Occupational Health, where they have this similar kind of guideline which they have published, more so ever for the medical staff, more so ever for doctors, nurses, and some of these spatial vaccine recommendation. I would like to share this very important incidents with you, that you must be wondering that why this rabies is being put under IAOH guideline. And I remember a year back, or three years back, pre-COVID, there was a case of a child who was having a kind of a suspected rabies, was brought to the PICU or pediatric ICU, and where the child was intubated by a group of interventionists, more so ever from anesthesiologists and nurses. And then suddenly it was seen that the case was found to be of rabies, and then there was a much huge hue and cry in the entire unit, in the ER as well as in the emergency, where it was asked that how many of them have already been taken these ARV or anti-rabies vaccine, and we need to go for a risk assessment in order to understand that how many of them would be needed rabies vaccine or immunoglobulin. So these are also vaccine recommendations for healthcare workers, which was suggested by IAOH. So this was which I was mentioning earlier also, that this is the vaccination schedule which is being provided by the Indian Academy of Occupational Health, and they've prescribed these vaccines starting from hepatitis B to rabies, and they've been made. We at our place at AIIMS Jodhpur are trying to build this kind of program where at least few of them should be made mandatory to our staff. This is again a recommended schedule for people who are traveling. Again, an effort which was made by Indian Medical Association and Associations of Physicians of India, where the three categories have been made. One is the routine category, the recommended category, and required, which is the mandatory category, where you can see that in, for example, a person going for any kind of congregation or events like Kumbh Mela or Hajj pilgrimages, where these kind of vaccines have been suggested, and rather they have been advised to all the people. This is just an example. Actually, I've taken an example of hepatitis B, and we all know that hepatitis B is an important vaccine which is being accepted by most of the healthcare professionals. And I think the most important reason is that we are at the highest risk of getting hepatitis B because of a constant and continuous exposures to our patient. And what we have found is that when we actually advocate to all our doctors that if in any case they are not being well vaccinated with hepatitis B vaccine, there is a need of an immunoglobulin, and which is of the order of 0.06 ml per kg, which adds to a lot of burden on their pocket also, and that may also not save them completely, adds value to the effect that most of our doctors are actually taking this vaccine. At our institution, it is mandatory from the side of the administration that each doctor should be vaccinated. And I remember, and most of you will agree, that most of the corporate hospitals have made it mandatory in a way that their pay slips are not, or paychecks are not released if they don't show that they've been vaccinated, and their antibody titer is not just seroconverted, rather seroprotected of the order of more than 10 IU per kg, which is said to be protected and not just seroconverted. Now, this is a glimpse because my topic was also the guideline and practices, what or how we are actually practicing it at our place. We have made few SOPs. This is just a glimpse of few of them. And whenever there is a patient or when there is a person who is actually coming to our OPD, we actually have a risk assessment form. We have their health status, and then we have actually categorized them into 3 categories, like routine vaccines or recommended vaccine or demanded by countries, if suppose there is any person in my OPD. This is again a glimpse of the another SOP which we have made for vaccines like pneumococcal vaccine or hepatitis B vaccines. And in our adult vaccination OPD, our resident, they used to take these histories, and then based on that, they follow a kind of an algorithm. And these algorithms are not made by us only. They, as I said, the guidelines which are issued by either Association of Physicians of India, IOH, or ACIP CDC guideline, we try to follow them up. For example, for this hepatitis vaccine, and most of us remember, if the case is of a chronic renal failure, then in chronic renal failure, the doses are to be doubled. And in that case, our resident need to know it, that it's not just to vaccinate the patient, but rather vaccinate him completely, because that can only save him from the risk of getting disease later. Again, a glimpse of, for example, this is the person who is actually coming to our OPD, and this is again the age-wise criteria as well as the spatial conditions, and these forms or these SOPs are available in our OPD, and which we follow with the help of our other guidelines. So I'm going towards the last slide, and thanks to my earlier speaker again, way forward we are looking for is, there is a need of now some national body like NTAGI. We have seen NTAGI's role in COVID-19, where they have proposed and provide us recommendation and guidelines for COVID-19 at the time, where these national technical advisory on immunization should take the task of adult vaccination, taking leverage from the COVID-19 time. Again, as earlier speakers have already mentioned, that it's the time to establish these adult vaccination units, centers, or OPDs with a true cut standard operating procedures. Again, as I said, the corporate hospitals have taken a lead in mandatory vaccination, but the public sector hospitals need to come forward to have these vaccinations mandatory for the healthcare workers. Yeah, as Professor Chandrasekhar and earlier speakers said, that it's the time to have an improved recording and reporting system for VPTs. That's very important. There is a need again for education and awareness for public. They need to understand that vaccines are not just for children, but they are for adults, and also to address vaccine hesitancy, whether there is delay, denial, but we need to understand that we have to address them very proactively. And there should be a systematic mechanisms for vaccinations of high-risk adult individuals, as I said, in our OPD, whether it is for cochlear implants, for chronic renal failure, whether it is splenectomy patients or multiple myeloma, there is a mechanism where they are not just referring them to us saying that they need these vaccines. Rather, they ask us, they take a proper advice from the vaccination unit, that what are the other vaccines which are needed beside what they know as a surgeon. And last but not the least is again the operational research, which is very much needed to generate evidence. So last slide, I would again say, which Professor Chandrasekhar said and my earlier speaker said, that it's the time to promote life course approach to immunization and advocacy, which I think I should thank the organizers, because they very nicely have gathered this very important theme and organized this very important event in terms of adult vaccinations, in order to advocate the policymakers that it's the time to start thinking in terms of adult vaccines. Thank you so much for such a patient listening. Thanks once again to the organizers for this opportunity. Over to the chair.
Dr. Kole. Hello. Hello. Hello, Dr. Kole is there? Probably some communication gap is there. So thank you, Dr. Bardwaj, for your very excellent deliberation. and very informative one. So we will definitely please sit back for a few minutes more, because we will have the question answers after this session is over. So may I request Dr. Gole? Hello.
Hello.
Dr. Gole, please.
So, Dr. Bhardwaj, thank you very much for your excellent deliberation. Our last speaker in this session, Dr. Sudeep Bhattacharya, and he will speak on life course approach vaccination in India. Sudeep Bhattacharya, he is a MD PGI Chandigarh. He is currently working in All India Institute of Medical Sciences, Madurai, as an assistant professor in the Department of Community and Family Medicine. He is now actively involved in undergraduate and postgraduate teaching, training, and translational research. He is also involved in multiple collaborative research projects with 10 countries: USA, Turkey, Canada, Greece, etc. Till date, he has published 100+ scientific research papers in the international as well as in national journals. And he is the editor-in-chief of Raji International Medical Journal, associated editor of Frontiers in Public Health, and editorial board member of BMC Primary Care, International Journal of Medicine and Public Health, Integrative Medicine Case Reports, Journal of Applied Sciences and Clinical Practice. He has received prestigious IPSM Ford Foundation Research Grant in 2017 as a principal investigator. He is currently working as a national project coordinator at Healthy Food for All Aims, Rishikesh. He is a life member of the IAPCM, IEA, AFPI, and IPHA. Dr. Sudeep Bhattacharya, please.
Thank you.
Life course approach in vaccinations in India. Life course approach vaccinations in India.
Thank you, sir. And I am audible to everyone?
Yes.
Okay. Thank you, sir. And thank you, the organizers, for highlighting this important topic and advocating this topic. This is very close to my heart topic. So once Dr. Satabdi called me, within a second, I just responded that I will join this lifetime, the adult vaccination program. So without already Bhardwaj sir has been told, so my pitch is little bit easy to play on. So I am sharing my screen. So I will discuss a little bit of life course approach vaccination in India. So the slide is visible, sir? Sir?
Yes, it's visible. Please make it full screen.
Okay.
Please make it full screen.
Okay. Now it is full screen, sir?
Yeah.
Okay.
Please continue.
Okay, thank you, sir. So I will discuss a little bit about life course approach vaccination in India. So these are my contents. So introduction, what is life course approach, the burden of vaccine preventable disease, challenges ahead, and conclusion and recommendation. So already we know and discussed by the previous speakers that is vaccine is a product that stimulates a person's immune system to produce immunity or antibody to a specific disease and protecting the person from that disease. And the whole process is known as vaccination, and already described, and it will be repeated multiple times through this program. That is, first ever successful vaccination was conducted by Edward Jenner, and use of cowpox serum to create immunity to smallpox patients. So this was the historical background. So what is life course approach? So till the last decade, the vaccines were mostly used among the children for eradication of vaccine preventable diseases, and new concept of life course vaccination came into the existence. Life course vaccination can be explained as by vaccinating and educating people about the vaccination throughout their lives. So whenever vaccination comes in our mind regarding the word vaccination, the picture of queues of mothers holding their babies in a immunization clinic, we used to picturize in our mind. So this is a common scenario across India as well as across the world. So life course approach is a new concept, but nowadays we need to focus on this. And life course mean each and every stages of the life of the vaccination process should be there, and setting based approach. Two things are important. One is across the life stages, that is pediatrics, adolescents, pregnancy, geriatrics, young, as well as setting based, not only hospital. It can be a school, it can be in college, it can be in workplace. So this concept, two main pillars are there for this concept, life course approach vaccination. So why we go for life course approach vaccination, and I am advocating these things before pre-COVID era, because with my limited knowledge, I thought that it is a very important for us, just like resource poor country in India, and the burden of infectious disease is so high. So emergence and re-emergence of infectious disease and world's aging population are the most important thing for this approach. And this is important to invest in the preventive methods like life course vaccination, and it is more crucial nowadays because already COVID has shown us the things what can be done. So after that, I will go for the few vaccine preventable diseases and its burden in India. So I have taken this from systemic review and meta-analysis regarding in India, that is hepatitis B. So India falls in the intermediate endemicity zone, whose prevalence is 2 to 7% with an average of 4%, with disease burden of about 50 million. And it is an estimation. And in US, compared to the US, hepatitis B related liver disease kills about 5,000 people and costs $700 million annually, which includes healthcare and productivity related costs. So we all know positive organism is hepatitis B virus, and preferred vaccination group under 5 children we are giving under UIP program, UIP. And other age groups, especially healthcare workers and factory workers and other workers, we used to give as a routine measure. Next is cervical cancer. In India, cervical cancer contributes approximately 6 to 29% of all cancers in women, and age-adjusted incidence rate of cervical cancer varies widely among registries. Highest in 23 per 1 lakh in Mizoram state, and the lowest is 4.9 in Dibrugarh district. Whereas in US, compared to the US, over 6 million new infections annually, and HPV strains cause 70% of the cervical cancers and also cause cancers of the anus, penis, mouth, and throat. So we all know HPV is responsible for that, and we have in our hand 2 time-tested as well as evidence-based vaccine. One is Gardasil. It is a quadrivalent one. Second is bivalent. It is given in the adolescent girls. So already we are giving many clinics regarding cervical cancer vaccine, but it is not incorporated in the immunization schedule. So it is not mandatory in India. Regarding influenza vaccine, a total of 1.2127092 influenza associated respiratory and circulatory deaths across all age groups occur annually in India. In US, compared to that, 3,300 to 49,000 deaths and more than 2 lakh hospitalization annually occurred, and over $10 billion in cost associated with a moderately severe seasonal outbreak. So it is recommended for all age groups. And unfortunately, we are giving for elderly in the India, just like immunocompromised patients in clinic-based or private hospital-based. Regarding end-stage renal diseases, regarding diabetes mellitus patients or any immunocompromised patients. So we are already giving, but not incorporated in the vaccination schedule for the other people, other than children. Similarly, dengue vaccine, the overall seroprevalence of dengue infection in India was 48.7% and increasing from 28.3% among children to 41% among the children 9 to 17 years and 56.2% among individuals aged between 18 to 45 years. The seroprevalence was high in the southern state compared to western and northern regions. So we have a vaccine that is called Dengvaxia. It is recommended for 9 to 45 years age, but it is not included in the National Immunization Program or schedule. So we all know about COVID-19. I don't go in the details regarding COVID-19 because multiple experts are there and detailed research has been done, and it still is ongoing regarding COVID-19 trials in India and abroad. So on today, near about 55 billion deaths have been occurred cases. Sorry, 5 billion deaths are present, and 5 billion cases are present, and deaths are 6 million. So in India, Covishield and Covaxin are the most prominent vaccine, and we have already given to the Indian population. It was previously recommended for aged 18 and above, excluding pregnant, lactating women and children. Later, it included the pregnant ladies as well as children above 6 years of age. So these are the few vaccines I have described, which have a tremendous potential for preventing the deaths as well as improving the quality of life and reducing the healthcare costs indirectly. And it is an investment. So this webinar is a breakthrough regarding vaccination process in India, and I hope that this initiative taken by the organization is very much fruitful for the future generation. So we need to advocate these things. So before pre-COVID era, we have done a research, and this is our proposed. Our team has developed a proposed life course approach background in India. Which vaccines can be given and how can be given, whom to given at what place. So these are the few vaccines we have. After brainstorming, we have come to conclusion that additional vaccines, just like hepatitis vaccine for adult and geriatrics, it can be given in the offices, NGOs, PHCs, old age homes. So by whom? It can be given by health officers, community health workers, volunteers, public health workers. Regarding human papilloma vaccine, adolescent girls can be given in girls' school and girls' colleges, as well as co-ed colleges, by school health nurses and health wellness ambassadors. Regarding COVID-19 vaccine, adults and geriatrics, offices, NGOs, PHCs, old age homes, by health officers, community health workers, volunteers, public health workers. Influenza vaccine, children and adult geriatrics, it can be given at offices, NGOs, PHCs, old age homes, schools and colleges, and Anganwadi centers, given by healthcare workers, volunteers and public health workers. So this is a conceptual framework we have devised and we have recommended to the higher level, and it is published in American Journal of Public Health in 2019. So the challenges ahead, because when you do new things, challenges will be there, and already vaccination intake is doing excellent job regarding pediatric vaccination or under 5 vaccination. So the challenges I have summarized, it is taken from multiple systemic reviews and meta-analysis in India, across the world also. So first is lack of consensus by the national organizations regarding the strategies for adult vaccination. So we don't have any consensus. Next is the surveillance data regarding the burden of infectious disease from India is lacking. So data is very much important for making any policy or making any decision. Until and unless we don't have any data, we cannot conclude or we cannot recommend any new recommendation. The major challenge what drives people against the vaccination is their perception and attitude towards it. Recently, we have surveyed it. I am a part of a multi-country survey, that is 20-country survey regarding vaccination of COVID vaccination, their perception and attitude. Though vaccination or vaccines may be changed, but the perception and attitude will remain same, as we are all human beings, though we are divided by cultures and other things. But ultimately, my experience says that perception and attitude towards same. And this study, multi-country study, we found that the main drivers are, one is cost of the vaccine. If it is government is giving free of cost, then people are willing to take this vaccine. Next, second thing is that the knowledge about the vaccine. Third thing is that the data, the trial data should be on the public domain. What is going on and what are the findings of the new vaccines? That is evidence-based. And next is healthcare. The people from healthcare, their advice, their recommendation, and especially public health nurse and Anganwadi worker or ASA worker, their motivation. These are the important drivers for keeping up the vaccination regarding all populations. Many barriers which can be addressed include organization barriers, patient-related barriers, which includes inadequate knowledge and awareness, negative perception and attitude, low health literacy. So my friends, for my juniors, I want to say that don't mix up health literacy with health education. Health education means we all know we have to wear a mask regarding for COVID in places where gatherings are there. But health literacy, what we are observing, that we are putting our mask below the nose. So we are not literate enough regarding health. We are educated that mask is important, but we are putting the mask below the nose. So it means health literacy is low, not health education. So health literacy is little bit about the action. Healthcare system barriers, that is lack of prioritization of the vaccines, lack of recall system and delivery, lack of monitoring and data, and most importantly, lack of funding. Although in 90s, At 1800, regarding First World War and Second World War, vaccine diplomacy, vaccine science diplomacy was initiated, and we have to percolate this down also, because vaccine science diplomacy in that era, Soviet Russia, the US scientists went to Soviet Russia for providing the vaccines regarding vaccine science diplomacy. So it is nowadays, it is missing due to political ideology, difference in the political ideologies. So vaccine science diplomacy should be bring back to new world. Healthcare provider related barriers, that is inadequate knowledge and awareness, negative perception, attitude, lack of effective communication with the patient, and especially now we are working in the, we are surrounded by the area of that is Facebook, WhatsApp, that is social media, and infodemics nowadays is very much important. There's a lack of information, wrong information, and it spreads like a wildfire. Though later the Facebook and other software companies has been a fact checker is there, even WHO also doing the fact checker things, so it is restricted now. Still, infodemics created a major problem for vaccine uptake. Socioeconomic factors, lack of inaccurate information in the public media, anti-vaccine movements, denial of the disease risk, and overconfidence vaccine paradox. These are the challenges, major challenges in our vaccine delivery system. Case study, I am describing a case study in 2018 from an institute of national importance. A total 1,383 individuals attended the adult vaccination clinic, and the study found that majority received tetanus toxoid and 20% individuals who received post-exposure prophylaxis for dog bites. And only 15% individuals got pre-exposure shots for yellow fever vaccines, and 8% for hepatitis B, 7% for pneumococcal, 3% for typhoid, and 1% against influenza vaccines. So you can see this from these figures that the vaccine uptake is very low regarding adult vaccination. So quickly, I am already in the time. So conclusion and recommendation: life course approach vaccination, immunization, or vaccination recommendations are wide. And in countries like Poland, Romania, and Bulgaria are practicing life course vaccination. And in our opinion, the world is to witness many epidemics. Previously Spanish flu, next is influenza, due to emergence and re-emergence of the disease outbreaks, and threat of emerging diseases quite real. The burden will be huge for India. We have already faced the problem or faced the burn or heat regarding the COVID situation. Even oxygen, basic things we are unable to provide at the crucial moment, and many deaths has been occurred. So we can understand, or we can learn the lesson from we have gone through regarding COVID vaccination. So burden will be again huge if we don't take up this issue very seriously. And it seems the right time to allocate resources to uptake the vaccination beyond childhood. Vaccination may be given to non-healthcare settings, that is settings-based approach. This is one of the major pillar of setting-based approach. And this seems the right time to adopt a setting-based life course approach for at-risk persons with the right vaccine at the right time and the right place, regardless of their age. So age component we have to clear from our mind. Age is not important nowadays if we go for life course approach. But few things we have to make clear in our mind, because we need to be ethical. These are the problem from other countries faced also. Vaccine allocation, vaccine distribution, vaccine implementation, or vaccine administration should be very ethical. Next is scientific evidence based. So we are already giving vaccines in private clinics and other way, but we don't have data. I am again telling data driven policy is very much important. So evidence based is very much important. Unfortunately, we are witnessing some things, unscientific things, and I am telling about only for science. As an example, if somebody is suffering from any infection, viral infection or bacterial infection, and his antibody titer, he is recovered and antibody titer is very high, natural antibody titer is very high, and if we know that antibody will remain for 9 to 12 months, unfortunately we are giving the booster dose of the vaccine. So this is not science. So we have to make our things very clear, simple, and scientific. So who person having natural antibodies in high level, we should not go for booster vaccine. The natural antibody will much superior, much long lasting than these artificial or passive antibodies. Data driven policy, again I am telling we don't have data, so step by step we can start regarding collecting data and integrating the all data. We can do that by data triangulation. We can do by using softwares, and we can collect, or we can make a network of, just like government is doing. We can do the same thing in private setup also. So data can be available. Data should be available for scientists as well as other policymakers, so that policy can be taken care of. Next is cost effectiveness. This is very much important for a poor country like India. We have to consider the cost effectiveness of this vaccine delivery system or vaccine delivery regarding life course approach. So it is easier to say, but very difficult to implement. So these 4 things we have to keep in our mind regarding introducing new vaccines to any particular age group. So these are my references, and thank you the organizers, especially Dr. Kole, Dr. Satabdi, and Dr. Rivu, for giving me this opportunity to talk with the eminent persons. Thank you very much.
So thanks, Dr. Bhattacharya, for your excellent deliberation. And in fact, we have got a lot of questions. So a lot of questions. This is the mainly regarding this, how this a consensus guideline can be performed in our country. Most of this is the question. So another question is that regarding COVID vaccinations. Tomorrow we have a separate session on COVID. We are not going to discuss on this issue. And another question is that what are the impacts of adult immunization as compared to children immunizations at public health level? I think this question is from Arun Kumar, Bangalore. I think Dr. Chandrasekhar, whether you can enlighten this issue.
Sir, can you repeat the question, sir?
What are the impacts of adult immunization as compared to children immunization at public health level? You have already discussed.
Yes, sir. In my slides, I have mentioned, sir, one simple principle, sir. Any vaccination, so will seroconvert, and it will protect, give the protection in the form of immunity to a certain period of time. So if the children is given, so probably by 15 years or an adult age group, that vaccine immunity will be waning off. So then we need to give the booster doses. So universal immunization is there, very perfect. All those 10 diseases, they are giving it. And even the pregnancy people are also giving with some comorbid conditions like TT and all, they are giving. And some risk, healthcare professional risk, for which HIV, HBSH, HCV are all are giving. But thing is that, so very risk population also is there, very elderly, more than 65 years. So they will be, by that time, they will be having as immunosenescence, and they are more complicated by other comorbid conditions like hypertension, diabetes, COPD, CAD, CVA, and all those things. So because of that, that immune vaccination also cannot take up, cannot give the immune benefits as it was in the adult age group. So the adult age group, so before they are attaining the elderly, so it is a life course, like say for example, one vaccine is giving the protection for up to 5 years. So every 5 years, so you can continue those vaccine, so that even at the end of the age also, so they no need to take, and there is no fear of that immune take-up is there or not. So this is an advantage, and definitely we are preventing so many infections, and that preventing the infections means we are preventing the morbidity, we are preventing the hospitalizations, we are saving the health course resources. So what are the benefits which we are getting with the child immunization? So we are also getting with the adult immunization, and this will be taken to the elderly also. So because the elderly people are going to increase in those days. So definitely it is as good as all the benefits which we are getting for our children, also we are going to get when we take up this adult immunization, sir.
So thank you, sir. Thank you, sir. the last question is that there are lot of questions regarding this, that regarding the guideline for adult immunization. I know that different societies have some different guidelines also. Whether any guideline is existing in our country, or if not, what are the efforts should we take to form these guidelines? So these are the lot of questions on this issue. Dr. Pankaj Bharadwaj, please.
I think Pankaj Bharadwaj sir has left because he has to go for another meeting. Sir, what is the program today we are conducting is serving one purpose, sir. That is, we are bringing the awareness of this adult immunization, first healthcare professionals. And the second thing is same education awareness should percolate down to the even general public also, sir. And the second thing is that there is no consistency in the guidelines. So, for example, if you take the Physicians Association and Gynecologist Association, Nephrologist Association and Pediatric Association, so they are having their own guidelines.
Yes,
so
yes.
what effort we have to bring is, so all these associations sit together and sort out, so which is acceptable for all these organizations and India at a large. And other stakeholders are government itself, sir.
Okay,
so
sir,
government can enforce bringing all these like task force comes, if the NTAG is there. So
Okay,
that way
thank
they
you.
have to call experts from all the fields and all these professional bodies like API, RSSDI, and should have a steering committee so that they can
Okay, sir, okay, we understood that all the societies should come together and we should plan in a better way.
sir, that is my opinion,
Is
sir.
here. Dr.
That is
Amita
my
Bonandi?
opinion, sir.
Dr. Amita Bonandi? No. Anyway, so thank you very much all the speakers for your deliberation, and we are going to I think that all the participants have learned a lot from your deliberations. We are concluding these sessions, and our next sessions will be started in a hall A and hall B simultaneously. So thank you very much.
Thank you, sir.
আমার কিছু না স্যার, এবার রোহিত স্যার আসবেন, রোহিতকে ইন্ট্রোডিউস করতে হবে। এই হল এটা তো Hello, very warm welcome to everyone. Our chairperson, Dr. H.K. Gohil, all our very respected speakers and august audience. Now we are going to start the session in Holi. I am Dr. Shatabdi Mitro, moderating this session. Dr. H.K. Gohil has done his post-graduation in public health from All India Institute of Hygiene and Public Health, Kolkata. He has worked as CMO in charge of ARV Center and Rabies Ward of ID Hospital, Delhi. Sir has worked as Deputy Health Officer, North Delhi Municipal Corporation, and is associated with APCRI as a life member since 2002. Sir is also a life member of Consortium Against Rabies in India. Sir is life member of Indian Public Health Association. Sir has published many papers in APCRI journal and other various national journals. He has done the research project on post-exposure prophylaxis for rabies at Pasteur Institute and Shambhunath Pandit Hospital of Kolkata. Sir has taken lecture for rabies awareness at many places in and outside Delhi. Sir, please take the seat of the chairperson and conduct our session. Welcome, sir.
Thank you, Sonal Shah. First, I thanks to the organizer who invite me as a chairperson for this interesting topic. Thank you so much for this opportunity. Rabies. The origin of the word rabies is derived from the Sanskrit word rabas, that is to do violence. In India, in about 3000 BC, the god of death was attended by a dog as the emissary of death. In modern day India, rabid dog still cause the death of 20,000 people each year, and 17.4 million animal bites occurs every year. The first written record of rabies causing death in dogs and humans is found in the mosaic Ismuna Code of Babylon in 2300 BC. On July 6, 1885, a 9-year-old boy named Joseph Moister was mauled by a rabid dog. Louis Pasteur inoculated first rabies vaccine to Joseph and saved his life. So practically rabies is 100% fatal with no cure, but 100% preventable. One human rabies death every 30 minutes, one animal bite every 2 seconds. Rabies is reported from all states except Lakshadweep and Andaman and Nicobar Island. 96% of human rabies cases are due to bites from rabid dog. Majority of the death occurs due to delay in poor compliances, lack of awareness, negligence, non-affordability, lack of transportation, non-availability of rabies immunoglobulin or vaccines, delay in starting treatment, or local application of irritant like chili powder, turmeric powder, oil herbs to bite wound. But it is 100% preventable if proper wound washing is done properly, rig infiltration in and around each wound, and vaccination as per national guideline. So now I invite our first speaker, Dr. Baisakhi Maji. Dr. Baisakhi Maji has done MD in community medicine. She has joined West Bengal Medical Education Service in 2017. Presently posted as assistant professor at ID and the BG Hospital, Baliaghata, Calcutta, which is the state level infectious disease hospital for managing various infectious diseases and rabies. She is a member of IAPSM and Association for Prevention and Control of Rabies in India. She is the member of the editorial board of APCRI journal. She has several publications in different national and international journals. So I welcome Dr. Baisakhi Maji. Dr. Baisakhi Maji, please.
Thank you, sir. Thank you, the organizer, for giving us this wonderful platform.
Dr. Maji, can we help you somewhere?
I am not able to sharing my screen.
Okay, ma'am, there would be a green color box on the bottom of your screen which says share screen.
That I have opened, but screen is not sharing.
Okay, ma'am,
I'm
have you
getting-
opened your presentation? Have you opened your
Yes,
presentation,
yes,
ma'am?
yes.
Ma'am, then it would be saying that these are the options of sharing.
Can you share my screen if I share with you?
Yeah, ma'am, can you share me the presentation? We'll do it.
Yes, yes, yes.
Yeah. I'll just chat during the. I'm just putting a message on the chat box for my mail ID.
Can you put it in WhatsApp?
Okay, ma'am. Sir, would you like to shift it to second session meanwhile, or we will continue this? Because it will take around 2 more minutes to arrange the slides and share on
This
the
is
screen.
better to invite our second speakers.
Yes, sir.
Then next, Dr. Baisakhi.
Sure. So meanwhile, I'll arrange the slides. We can move
So
ahead.
by
sir.
the time Dr. Bhushaki's slides will be prepared, and yes.
So I invite after our second speaker, Dr. Sumit Poddar. Dr. Sumit Poddar, a fellow at Royal College of School of Tropical Medicine, is a member of Indian Society of Critical Care Medicine. He is presently the Secretary General of Association of Prevention and Control of Rabies in India. He has been a long-time member of the Indian Public Health Association. Attached in anti-rabies unit, Shambhunath Pandit Hospital, and medical officer since 1984 to 2010 at Shambhunath Pandit Hospital, Government of West Bengal. Dr. Poddar has a wide range of experience in the medical domain. Dr. Poddar is an avid researcher and has research paper published in some of the reputed journals of the world. Dr. Poddar believed in giving back to the society and has led the disaster management team since 1984 to places like Latur earthquake, Odisha cyclone, Gujarat earthquake, Nagapattinam Kadalur, and Andaman during tsunami, Myanmar, Bangladesh, Nargis cyclone, Nepal earthquake, Jammu and Kashmir flood, Kerala flood, and many more. So welcome, Dr. Poddar. Dr. Poddar, your speaker is not on.
Okay, I think I am
Yes,
audible.
yes, audible. Yes, now.
Dr. Kote, I am audible. Audible?
Dr. Poddar, you are audible.
Yes,
Can
sir.
you hear me? Hello? Hello?
Yes, sir. Loud and clear, sir.
Hello?
Clear, sir.
Hello?
Yes, sir.
Hello?
Audible, sir.
Sir, you are audible.
Hello?
Audible, sir. Loud and clear, sir.
Can you hear me?
Yes, sir. শুনি এটা আবার দেখাতে বলছে
Hello?
Yes, sir. Audible, sir. Audible.
Okay. Let me start.
Yes, sir.
Thank you, Dr. Saurabh Kole and the chairperson of this session, Dr. Hemant Gohil. Also, I'm thankful to each and every speaker that are presenting in this in this program. And one thing, what I want to tell that my subject is scope for the dose reduction in anti-rabies management, and it is the need of the day. Can you hear me? Hello?
Yes.
One thing, my topic is scope for disease dose reduction in anti-rabies management, and that is the need of the day. After that, David Sample came, and in the year of 1911, he developed samples nerve tissue vaccines. But these nerve tissue vaccines are very much neurotoxic vaccines, damages the myelin sheath. So it has ultimately gone replaced by the our modern tissue culture vaccine. Now initially we started with nerve tissue vaccine, the modern tissue culture vaccine. The dose of nerve tissue vaccine was near about 14 doses in the anterior abdominal wall, and also then replaced by the tissue culture vaccine that was 5 to 6 doses, then replaced by 4 doses intradermal rabies vaccination, as well as modified schedule is now that is only for 4 doses vaccination is coming. It is already in the process. Now the most important thing, now the time has come to bring such a vaccine which is definitely takes minimum dose, that is day 0, 7 and the 0, 3 and 7, thereby releasing the antigen slowly and produces a high A of antibody response. So this is my topic, and we are also definitely coming with the Rabies, a normal vaccine. It's a G protein vaccine, and with the VLP technology, that is a virus like protein technology. It is already in the market, and the dose is definitely 0, 7, 0, 3, and 7. So within 3 doses of vaccine, we are definitely managing the. Next important thing is vaccination is the administration of a vaccine to help the immune system to develop the immunity from a disease. Most vaccines are given by an injection, but some vaccines are given by orally and sprayed into the, of course, into the nose. The role of that vaccines is produces antibodies, and antibodies are the proteins produces naturally by the immune system to fight against the disease. So their present vaccination in case of anti-rabies management is number 1 is intradermal, that is 4 dose, 0, 3, 7 and 28 days. Asian schedule, the intramuscular started with 4 to 5 doses, and that is 0, 3, 7, 14 and 28, replaced by modified Asian skipping the day 14 dose, and also it is in some places it is already in practice. And another important thing is the Zagreb schedule, that is the intramuscular dose. It is not usually carried out in our country, but it is in outside the country that is being followed in 4 doses schedule. That means day 0 is a 2 dose, and day 0 is a 2 dose, day 3 no dose, J1 is the 1 dose, and day 21 or 28 is another 4 dose. So this is actually a picture. So next, immunization can be achieved in an active and passive manner. The vaccination is an active form of the immunization. The vaccination, of course, is an active form of immunization. Next is our anti-rabies vaccination for post-exposure prophylaxis is number 1, WHO recommendation. Also trying, that is 2-site intradermal, that is on day 0, 3 and 7. This is the WHO proposal, but not already started in India, because India is an endemic country, so it is not being carried out. in 2 weeks, that is one side intramuscular days GP. The main thing is this 2 week schedule also usually carried first time by Deborah Briggs, and she has already skipped that day 14 dose and replaced it by a single dose from day 14 to 28 days. That is usual dates for the vaccination. Another is 3 weeks already I mentioned. That is the JAGRIP schedule, 2 sites on day 0 in the intramuscular site, and day 7 is another dose, skipping day 3 and also skipping day 14 also, that comes onto day 21. Now, what we are planning also to minimize these doses also. We are simply, the time is an invaluable part of our life. So, and time is the precious gift of God. We cannot waste time. If we can continue the vaccination from day 0, 3 and 7 and complete the vaccination, that is a wonderful thing. Now the most important one, the first company globally has come with a very good VLP technology. That is the main thing, 3-dose schedule, 0, 3 and 7. Of course, in the management of dog bite cases, we have to give, in case of category 3 exposures, that is the rabies immunoglobulin administration should be given along with this. And there should be much more studies, as because it has come very recently, particularly what happens, what is the antibody response that will come in case of immunocompromised disease. Also, they have tested it that it is also been applicable to immunocompromised patients and also can be given and completed the dosage by 3 doses of vaccine. The only demerits of this vaccine is, number one thing, it is only just form, it is a liquid form of vaccine, then we cannot give it intradermally. So whatever we will have to use this vaccine, that only in terms of intramuscular doses. Other standard protocol is other tissue culture vaccines that we are using for a long time. That's 4-dermal or modified Asian dose by 4-dose Asian schedule modified. That is also 4 dose. And also these vaccines are being utilized properly in the management of animal bite wounds. And in addition, in case of category 3 cases where there is a bleeding, minimum bleeding, that that portion of the wound should be equally infiltrated with rabies immunoglobulin. Now, 2 terms of rabies immunoglobulin are there. One is the rabies equine immunoglobulin. The dose is 40 international units per kg of body weight. Another is the human rabies immunoglobulin. The dose is 20 units per kg of body weight. Then they think that if we can give, but the human rabies immunoglobulin is very much costly. So to adapt with that cost, now 2 things has already come in the market. That is, one is the our rabies monoclonal antibodies. That is being given at the dose of 3.33 units per kg of body weight. Another important thing also, that is also another is there, that is twin there, that is a combination of 2 such things, and that is also being utilized at the dose of 14 units per kg of body weight. So any patient in the post-exposure anti-rabies treatment comes with us, what we do, we definitely give, number 1, as per categorization of the wound, rabies immunoglobulin, and then vaccination. Vaccination will start working on day 14, where we'll get the maximum our already the antibody. That is the thing, the highest antibody that will be peak on day 14. That is the concept. Now we can also reduce the scope, reduce the dosage. If we can reduce with this technology, I personally and believe that one day will come, then the vaccine will come, which will release slowly the antibody and will last for a longer period. We are giving antigen, and that will release antibody that will protect the patient and for a longer period of time. So this is the need practically to develop such vaccines, and already Cadila Pharmaceutical has come with Travis. The name is Travis with GLP technology protein, G protein vaccine. That is also, we are also starting uses and also starting using these vaccine with a good antibody response within only 3 doses. Now, as per the treatment, I think it will be taken by some other speaker. Dr. Maji is there, she will speak on category 1, category 2, and category 3. But the main guidelines is prevention is better than cure. We cannot cure a patient with rabies encephalitis. So, two things are very important. One is the post-exposure prophylaxis, that is full doses of vaccination, and with this the minimum dose of vaccination will protect the patient. Another is the pre-exposure prophylaxis. Now, this pre-exposure prophylaxis means we'll have to give 3 doses of vaccine, and then if the patient comes with in the post-exposure period, the patient will get only 2 doses of vaccine. And definitely another part is there, that is the re-exposure prophylaxis. That means the patient has received already the 2 doses of 2A of the vaccine, post-exposure prophylaxis or pre-exposure prophylaxis, both, and report to us in a re-exposure case, the patient will need only 2 doses of vaccine, and moreover, rabies immunoglobulin will not be required. That is the most important part. So, current treatment modalities, number 1 is the wound wash, then do our categorization. Treatment of category 2 cases are very important, treatment of category 3 cases. Now, one thing is very important in case of treatment of category 2 cases, where there is no bleeding, only the scratch mark is there or bite mark is there without any bleeding, that patient requires only vaccination. But one thing, in case of immunocompromised patient, then it should be inspected meticulously, and if needed, additional rabies immunoglobulin has to be given. And category 3 treatment, wound wash is the common in all cases, 15 minutes under running tap water with soap and water. That already washes the virus for at least 15 minutes. We have to wash it. At least 50% of the virus can be washed properly. And category 1, category 2, and category 3 is there. There are also some difficulties also treating the category 3 cases. Now, one thing I am telling, a patient with severe bite wounds all over the body, that patient, the dose has to be recalculated, and the quantity is insufficient. The rabies immunoglobulin has to be given properly. In case of big size wound, it should be diluted, half-fold dilution, or 1/4 or 1/3 fold of dilution is needed with normal saline. But one thing should be kept in the mind, that all the wounds should be properly infiltrated with rabies immunoglobulin. Another important problem we are facing, suppose the children of only 10 kg or 5 kg body weight with a big wound, then the dosage of the vaccine of the rabies immunoglobulin is not sufficient even after dilution to infiltrate all the wound. These are difficult cases. We'll have to treat it accordingly. Number important thing in these cases, I think the dose reduction plays an important role. When there will be proper antigen and should generate proper antibody with a shorter period of time, will last for a longer period of time, at least covering the 3 months of time, that is the incubation period of that particular age. So future vaccination means human deaths are due to rabies are reported mainly from the endemic areas in Asia and Africa. Now, improved vaccine strains, it should be improved vaccine strains that are more immunogenic due to the increase in copy numbers of the G protein, that technology, and may reduce the need of multiple immunizations in humans and thereby reduce the cost of vaccination. And that is the basis of these particular reducing the minimum dose of vaccine. User-friendly delivery system should be there, and improved vaccine formulation should be there, and also versatile combination vaccine for the dogs. That is also another part of the management of the rabies. Universal weights of ORV and a One Health focus that should be kept in mind of canine rabies elimination, considering the eradication of smallpox and other diseases and considerations for similar strategies targeting polio, measles, etc. A WHO Assembly resolution would enable to the technical ability and economic resource necessary to achieve the above proposals. So these are very important things.
15 minutes.
And also lastly, next generation of rabies vaccines are live attenuated, inactivated genetically modified rabies vaccine, inactivated adjuvant traditional rabies vaccines, and other incomplete with DNA vaccines, RNA vaccines, viral vector vaccines, and all these things are the next generation of rabies vaccine. So
Dr. Poddar, please conclude it. More than
yes, sure. Just within 30 seconds. Produce a vaccine which will slowly release antigen, that is the base, will stay for a longer period. Cost-effective treatment is also very much needed. So there are references also there. So main thing, main references from the Anderson and also Jackson, Dr. Jackson also is there. So we will have to proceed for a good approach towards the animal bite management cases, where we will see with a low dose, with a minimum dose of vaccination, we can protect that human, and also within 3 doses of vaccination will definitely already came, and in future it will be, we can reduce or cannot reduce that, the time will speak, and in future definitely will be able to achieve the goal. Thank you very much.
Thank you, Dr. Poddar, for very informative and wonderful presentation, especially for world first 3 dose of anti-rabies vaccine, that is recombinant rabies G protein. Due to 3 dose, that is a less visit to the hospital or clinic and less absent from duty or school. So in this term, it is economical, and there is a already diluted, it is not required for dilute further. Thank you, Dr. Poddar. Now,
thank you, Goril.
Now our first speaker, I invite our first speaker, Dr. Baisakhi Maji. Dr. Baisakhi Maji, please start.
Thank you, sir, and good evening. In this section, we will deal with anti-rabies prophylaxis as per the current situation according to our National Rabies Control Program guidelines. As we know, rabies is 100% preventable with prompt and thorough appropriate treatment. So before initiating this, we have to know where to give this anti-rabies prophylaxis and in which bite we do not need to go for anti-rabies prophylaxis. The most frequently encountered animal bite injuries and rabies cases are due to dog and cat bite in India. Next slide. Sometimes monkeys, horse, fox, cow, buffalo, donkey, pig, sheep, these animals also can transmit the disease. And occasionally camel, mongoose, jackal, deer, tiger, and all other wild animals can transmit rabies in India. Remember that any wild animal bite injury is usually considered as rabid animal bite and deal accordingly. Next slide. In India, bite by house rat, mice, birds, rabbit, or even bats are not reported to cause any rabies cases. So bite by these animals will not be requiring any anti-rabies prophylaxis. Next slide. Next slide, please. This is a tiger bite victim attending our anti-rabies clinic in Belekata ID Hospital. You can see the severity of the injury. And now coming to anti-rabies prophylaxis. Next slide, please. There are 3 types of prophylaxis. One is pre-exposure prophylaxis. Next slide, please. The schedule of pre-exposure prophylaxis, one full dose of intramuscular or intradermal anti-rabies vaccine on day 0, 7, and 28 or 21. The indication for pre-exposure prophylaxis is for high-risk groups personnel like laboratory staff who are handling rabies viruses and infected materials, healthcare workers attending the human rabies cases or treating the cases, veterinarians handling the rabid animals, etc., animal handlers and catchers, and travelers from rabies-free countries to rabies endemic areas. And those persons, after receiving pre-exposure prophylaxis, those who are in continuing risk of this exposure to the viruses, should go for taking the neutralizing antibody titer every 6 months for the initial 2 years after the pre-exposure prophylaxis. If the rabies antibody titer in serum is less than 0.5 international units per ml, then a booster dose is required. And if it is more than 0.5, then booster dose is not required presently. And after 2 years initial period, subsequent seromonitoring is recommended every 2 yearly for these persons who are at continuing exposure to this rabies virus. Next slide, please. Second part of the anti-rabies prophylaxis is re-exposure prophylaxis. Re-exposure is said when a person have previously received and have documented evidence of full pre or post-exposure prophylaxis either by intramuscular or intradermal route with a cell culture vaccine or purified duck embryo vaccine. They will elicit an anamnestic response to one or more booster doses of anti-rabies vaccine, even if the initial series was administered several years earlier. These persons, if exposed now with the animal bite injury, should receive only 2 booster doses of intramuscular or intradermal route on day 0 and 3 only. For these re-exposure categories, RIG administration is not required, but proper wound toileting should be done. Next slide, please. The third part of the anti-rabies prophylaxis is post-exposure prophylaxis, that is after exposure to an animal bite injury. We can follow intramuscular regimen, that is 5-dose schedule, 1 dose each on day 0, 3, 7, 14, and 28. Or we can follow intradermal regimen, that is 0.1 ml per intradermal site on both deltoids per visit on day 0, 3, 7, and 28. The dose for this intramuscular vaccine or the intradermal vaccine for all the age groups and the genders are same. That is, when a child is receiving the same dose as the adult. Next slide, please. Before going to post-exposure prophylaxis, we should be able to categorize the animal bite injury and determine what would be the treatment modality. For this, we follow WHO guidelines. The WHO category 1 is touching or feeding of animals and licks on intact skin. No post-exposure prophylaxis required. Category 2 is nibbling of uncovered skin, minor scratches or abrasion without bleeding. In this case, immediate anti-rabies vaccine and local wound washing is required. And category 3 is single or multiple transdermal bite or scratch injury, licks on broken skin, or contamination of mucous membrane with saliva from licks or contact with bats. Here, immediate anti-rabies vaccination along with rabies immunoglobulin administration and local wound management is necessary. Next slide, please. The principles of post-exposure prophylaxis is wound management, antibiotics if needed, inquire and provide anti-tetanus measures, and most importantly, anti-rabies immunization, which have 2 parts. One is active immunization with anti-rabies vaccine, and the second part is passive immunization with either rabies immunoglobulin or rabies monoclonal antibody, only in case of category 3 exposure. Next slide. For animal bite wound management, the wound should be thoroughly washed with soap under running tap water for at least 15 minutes. Then a virucidal agent, providon iodine or alcohol can be applied. Suturing is to be avoided as it increases local trauma and helps in larger tissue area to come in contact with rabies virus. If necessary, suturing can be applied with only 1 to 2 loose sutures, only to oppose the wound or control bleeding. But before that, local infiltration of all the wounds with rabies immunoglobulin should be done. Don't apply any irritants over the animal bite injury like lime, turmeric powder, chili powder, or never cauterize the wound. Next slide. Then active immunization with anti-rabies vaccine after proper wound management. Next slide. For intravascular vaccine schedule, we will go for post-exposure prophylaxis on day 0, 3, 7, 14, and 28. And those who have received previously any rabies vaccination full course, then there we can go for re-exposure prophylaxis on day 0 and 3 only. Next slide. For intradermal vaccination after the animal bite injury, we can go for 4-dose schedule on day 0, 3, 7, 28 on both deltoids with 0.1 ml of anti-rabies vaccine. And in re-exposure cases, we can go for 2-dose schedule on day 0 and 3, but on single source or single site anti-rabies immunoglobulin administration. Next slide. After active immunization, we can move to passive immunization only in case of category 3 bites with rabies immunoglobulin or rabies monoclonal antibody. Next slide. Indications are all category 3 exposure irrespective of the status of biting animals, all proved rabid animal bite or exposure, and this RIG infiltration is particularly important in immunocompromised individuals where the antibody response against anti-rabies vaccination is slightly doubtful. Next slide, please. Rabies immunoglobulin can be of two types. One is equine anti-rabies immunoglobulin or ERIG, dose is 40 international units per kg body weight. And second thing is human rabies anti-rabies immunoglobulin or HRIG, dose is 20 international units per kg body weight. Next slide. The dose for rabies monoclonal antibody is 3.33 international units per kg body weight. For an average adult man with a body weight of 75 kg, we need to administer 3,000 international unit of ERIG or 1,500 international unit of HRIG, whereas for RMAP, the dose is only 250 international unit. Next slide. Next slide. Mechanism of action of RIG or why this passive immunization is required. This RIG neutralizes the virus at the site of the bite and prevents its progression into the central nervous system. As we know that anti-rabies vaccine requires 7 to 14 days to produce measurable amount of antibody after the initial dose. For this 7 to 14 days of initial window period, RIG offers protection from the day 1. So RIG can be administered up to 7th day of the first dose of ARV. Beyond 7th day, that is after 3 doses of anti-rabies vaccine administration, RIG is not indicated as it can suppress the immune response to anti-rabies vaccine because by that time, antibody response is already there. It can be administered irrespective of the interval between the time of exposure and initiation of vaccine treatment. Even after months of animal bite injury, we can initiate the anti-rabies immunoglobulin and anti-rabies vaccine for preventing rabies in victims. Next slide, please. How to administer RIG? RIG should be administered the full dose, that is the full calculated dose as per the body weight, should be thoroughly infiltrated into and around the wounds if anatomically feasible. All wounds should be thoroughly infiltrated with RIG. If calculated volume is found to be insufficient to infiltrate all wounds, dilute it with sterile normal saline up to 2 to 3-fold. This type of scenario we usually find in case of bite over face and neck, in case of children especially, or in case of wild animal bite like tiger bite or a severe animal bite injury. But if there is any remaining volume of RIG that is not required for infiltration of all the wounds, then this volume can be injected intramuscularly at a site distance from the ARV administration site, but it cannot be administered in the gluteal region. Presently available rabies monoclonal antibody or rabies immunoglobulin preparations are very safe. However, equine serum must be administered with full precaution. Next slide. Animal bite victims should be kept under observation for at least half an hour after administration of equine rabies immunoglobulin because there is chance of anaphylaxis. And while administering ERIG in a hospital setup, we have to be prepared to treat any anaphylactic reaction with adrenaline age-appropriate doses. Next slide, please. Other general conditions for rabies immunization. Anti-rabies vaccine and RIG should never be administered with the same syringe, or these two should never be injected at the same anatomical site to avoid neutralization of their effects. Never inject it intravenously. Never inject the vaccine or RIG at the gluteal region. Because of the risk of interference with vaccine immune response, neither the dose should be increased nor a repeat dose of RIG must be given. There is no contraindication for rabies post-exposure prophylaxis, including those who are having pregnancy or even lactating women. No dietary restrictions are there during rabies post-exposure prophylaxis. Thank you for your patience hearing.
Thank you, Dr. Vaisakhi, for your wonderful presentation and very informative about pre-exposure prophylaxis, re-exposure, and post-exposure prophylaxis. In re-exposure prophylaxis, I add something that is the re-exposure should be treated as a phase case and giving full PEP if people who have previously received the full post-exposure treatment will neural tissue vaccine or vaccine of unproven potency, people who cannot document previously post-exposure prophylaxis and pre-exposure prophylaxis, and those who have not taken post-exposure prophylaxis in spite of animal exposure. So re-exposure should be treated as fresh case and giving full post-exposure prophylaxis. Thank you, Dr. Vaisakhi, for your nice presentation. Thank you. Now, our third speaker is Dr. Bakulesh Khamar. Dr. Bakulesh Khamar is Executive Director R&D at Cadila Pharmaceutical Limited, India since 1996. After obtaining his MS in 1980, he has been an active teacher and researcher and worked at M&J Institute of Ophthalmology, Ahmedabad, and NHL Municipal Medical College, Ahmedabad, Sankara Netralaya, Chennai, and School of Optometry, Berkeley, University of California, USA. His earlier part of the career was restricted to eye research only. In that duration, he developed KM medium for corneal preservation, device for visual activity prediction in presence of opaque media, device for visual field screening. He also received numerous awards, including Kol Rangachari Award by All India Ophthalmic Society for Best Paper. Welcome, Dr. Bakulesh.
Thank you. Thank you, organizers, chairman, moderator, my colleagues, and fellow friends. So during this talk, I'll just brief you about what we can do by changing the platform and make the vaccine safer and more effective. So essentially, vaccines are for a prevention of disease, and they need to be highly safe, highly immunogenic, and compliance is a key for any vaccine to be successful. These are some of the technology platforms which are being used for development of vaccines, and I'm just giving you the timeline against each platform. So if you look at it, smallpox used a heterotypic platform where identical organism but belonging to a different species is used, and it was used for BCG, but then it has not been widely used and you don't see any movement moving forward. Similarly, there's attenuated vaccines which use originally rabies, typhoid, inactivated viruses, flu, pertussis, rabies, injection polio, polysaccharides for pneumococcal, Hib, typhoid, conjugate vaccines for Hib and pneumonia and typhoid, recombinant using yeast as a platform, hepatitis B and HPV, and recombinant bacterovirus used for HPV and H1N1. So if you look at it, I mean, I'm just highlighting two important diseases which matters to India. rabies and typhoid. Originally, they were started as attenuated vaccines, but subsequently there has been improvement going on, and there is a change in the platform for better efficacy. So if you look at the typhoid, it started as attenuated, then it became a polysaccharide vaccine, and now it is a conjugate polysaccharide vaccine. So changing a platform with a better efficacy, better compliance is a norm in the vaccine industry. So if you look at what happened during the COVID time provided us old platform-based vaccine like live attenuated. One of the classic example of our country is a Covaxin, but it also provided novel platform in terms of Oxford vaccine, Pfizer vaccine, Moderna vaccine, DNA vaccine. So all these are novel platforms and which we'll be seeing more and more frequently in the future. So why we need a novel platform? To provide consistent protection, better characterized product, improved immunogenicity, which is measurable and consistent across batch to batch. So I'll show this by example of a rabies vaccine. So original rabies vaccine, which was invented by Pasteur, was a crude solution of a dry spinal cord containing rabies virus, where virus was from a rabbit which was infected and passaged 80 times. But the challenge was it needs to be prepared fresh. You can't transport it. And you can't produce in a large scale. And the dose was not standardized, and it ranged from 14 injections to 31 injections. And this led to Pasteur institutes worldwide, where they will grow the virus into the rabbit, harvest it, and provide it as a vaccine. It was converted into industrial production in US, and this is how it looked like. It's a spinal cord which is given as a 25 injections, and these injections are not of the same potency. You have to keep increasing the potency over a time, and that are the challenges. Then came how do we make it better? So from a attenuated, it became inactivated with the knowledge that phenol can be used to inactivate, and sample converted from a spinal cord to the brain tissue, and he standardized the amount of the brain which can go into it. So he reduced the amount of the neural tissue, which led to reduction in the side effects. But in spite of that, neurological complications were as high as told by Dr. Podar. It ranged from 1 in 300 to 1 in 600, and mind you, these are prophylaxis. And then there was a challenge of compliance because it required 14 injections to be given daily. So next came that, okay, can you minimize the neural tissue? So they started growing it into duck embryo, and it had a lower myelin content, so improved the safety profile, but the number of injections could not be reduced. Then technology and knowledge advanced, and we started growing it in a various medium which does not require neural tissue like varocell, HDC, or cheek embryo. And with improved technologies, we could remove large amount of extraneous material which are not required. And number of injections came down to 5 from 14. So this was a significant improvement. And this is a snapshot of what is difference between the three. And if you look at it, over a time, there's a reduction in the neural tissue with an increased immunogenicity and increased shelf life and decrease in number of injections. However, in spite of all this, it still remains a neglected tropical disease. Western world has by and large eliminated this, but still it is a country like us, it's still a problem. And every year, 59,000 humans die around the world as per WHO, and majority of them are Indian. And this, in spite of being a preventable disease, there's 100% mortality, which is not seen in any vaccine preventable disease. And that is probably the reason now it is catching attention of the government of India, and we have joined zero rabies by 2030. So what are the challenges? If we have achieved this, what are the challenges? The challenge is current 5-dose vaccine is safe, better immunogenic, but compliance is poor because of the complicated regimen. It's not a straightforward. First week, 3 injections, then after a week, another one, and then after fortnight, another one. And this leads to drop in compliance beyond 3 injections. So various studies which are listed below, they say that it is very difficult to complete 5 injections for everybody, and dropout rate ranges from 25% to as high as 54%. even with the 4 injection, dropout is 15% to 47%. So what can be done? The simple answer is, can we reduce the number of injections? Because number of injection reduction has seen that it is possible, because after 3 injections, everybody takes it, 4th and 5th, hardly anybody takes it. How do you do it? Improve immunogenicity will lead to decrease dosage. But how do we decrease the number of administration, which can make easy to follow regimen, and decreasing immunogenic material? That could be the answer. So what is the immunogenic material in the rabies vaccine? So rabies vaccine, I mean, if you look at a virus, rabies virus is a big virus, I mean, comparatively, but immunogenic protein is very small component of the virus. Rabies G protein, there are other proteins, but they are not immunogenic. They are not responsible for neutralizing antibody. So G protein is only immunogenic protein, which is responsible for neutralizing antibody. And as per the published literature, protective activity of G protein is significantly high. If you look here, 9 nanogram of G protein is equivalent to 1.63 microgram of virus. So significant reduction in immunogenicity, I mean, increase in immunogenicity is seen with G protein, and it's the only protein which neutralizes antibody generates. So how do we convert this highly G protein in a simple form? So we have a platform which we call is a recombinant baculovirus, on which HPV vaccine is already approved around the world. We ourselves have developed H1N1 and seasonal flu, and seasonal flu vaccine using this platform is also available in the US. So with that in mind, we try to develop rabies vaccine with the idea how much we can reduce the amount of administration of it, dosage, 5 to whatever number we can come. So it's a very simple to make, since it is a protein. You don't need sophisticated class 3 or environment to produce it, because you don't have virus anywhere. It is only baculovirus which converts back. This is non-pathogenic virus, which will provide recombinant protein through a process. So you grow the virus, you harvest the virus, you purify, and then that purified protein is your product. And in the preclinical study, we found that this purified protein gave a higher immune response compared to the Rabipur. This is our conventional 5-dose vaccine. And then it also gave a consistent response. If you look at consecutive 5 batches, provided very close to each other response compared to Rabipur, which is a little more divergent, and there's a significant batch-to-batch variation. And this was published. And with this, we came to the human, and we did one of the largest clinical study. So in a phase 1 study, we had 17 arms. Can you consider any product having the 17 arms in a phase 1 study? We tested 4 doses and 4 schedules. Dosage were 5, 10, 20, 50, and it was included only in 0.5 ml. And it need not be reconstituted. 4 schedule was 03, 037, 07, 07, 10. And Rabipur was used in a standard format 037, 14, and 18, 28 days. And everybody achieved 100% seroprotection level on day 14 and day 42. Then we went to phase 2, and again we evaluated in large number. Each test arm had 50 people. There were 4 groups, 2 for a dose level and 2 for a schedule level. And again, the findings were identical to phase 1. This made us to go into phase 3, and this phase 3 study is now published, and it is one of the largest clinical trial ever done for approval of vaccine, Rabipur vaccine or rabies vaccine. And there were 533 subjects in the control arm and 267 in the test. I mean, control arm and 533 in the test arm, and it was given in a 037 schedule, and Rabipur was given in the standard schedule, and it contained 50 microgram of protein. And these are details of the trial: primary objective, secondary objective, primary endpoint, secondary endpoint. And this is a snapshot how it was done. So how the blood was drawn, what was the samples taken. And this was a non-inferiority trial with a primary and secondary objective to provide 14-day post first dose and 42 days post first dose, and safety as a secondary endpoint. Standard inclusion exclusion criteria, all were healthy volunteer without any evidence of immunodeficiency. No pregnant women were included, no lactating women were included. And both the groups were identical. If you look at baseline characteristics, there was no difference in both the groups. If you look at age, height, weight, the demographic were same, and we achieved identical results. So seroprotection on day 14 and day 42 were identical in both the groups. And so our product was found to be as good as Rabies PEP, and DCGI approved it. But that's not all. With 3 doses, we can do what 5 doses does it. But there's a significant advantage in the adverse event profile. Very few adverse events were seen. I mean, in total, if you look at the numbers, but if you even look at injection site reaction, localized pain was significantly low because it's highly purified protein. So this vaccine reduces the number of doses and provides same level of protection. And this is first subunit vaccine, which is a 3-dose vaccine. And this is made possible by use of novel platform, which is baculovirus recombinant technology. And with this tech platform, we are trying to develop 2 more vaccines, which will be herpes zoster vaccine and HPV vaccine. And this is our guiding philosophy, our founder chairman. He always believed innovate in India for India and make it available to the last mile of the society. Thank you very much.
Thank you, Dr. Bakules, for nice presentation and very informative, and especially for dose reduction. It is like 31 dose to 14 dose to 5 dose to world first 3-dose anti-rabies vaccine. So you are given details about novel 3-dose recombinant non-particle rabies G protein vaccine. The novel 3-dose recombinant rabies G protein vaccine administered as stimulated post-exposure prophylaxis was non-inferior to 5-dose WHO pre-qualified vaccine in terms of safety and immunogenicity. Thank you for your nice information.
Thank you, sir.
Now I hand over mic to the organizer.
Dr. Oda wants to say something.
Yes.
Yes, sir. Sir, your phone is muted. Sir, you are muted, sir.
Okay. Now, am I audible?
Yes, sir.
Okay. One thing regarding the administration of rabies immunoglobulin, that is only one part. And suppose a patient bite in the tip of the finger and the body weight is near about 80 kgs. That means he needs at least 10 ml of if we administer rabies immunoglobulin in the form of equine origin. Okay, we'll have to administer at least 10 ml of rabies immunoglobulin. Now, only the important thing is, in those cases, it is very difficult. So, another important part is, we should not give the vaccine with the rabies immunoglobulin in a subsequent less dose, because the main objective is to neutralize the virus at the site of the entry. So whatever we'll have to administer, that the rabies immunoglobulin in that particular area, not in the other gluteal region or a. That is already, I think it will be replaced very soon, that the need of the rabies immunoglobulin administration, at least we'll have to give the main part as well as surrounding part. There is a limitation of administering the vaccine, the rabies immunoglobulin in that separate site, that is in the gluteal region. That is the only thing that I want to first comment.
Thank you, sir. Thank you,
Dr.
Gahil, sir, and all the speakers, Dr. Boishakhi Majhi, Dr. Khamar, sir, and of course, Dr. Sumit Poddar, sir. Few appreciation comments have come in our chat box, and one question that if a child aged less than 1 year can be given with the rabies vaccine, And also the same question, that is the child less than 1 year can be given with the immunoglobulin.
Of course, this is the only thing that where we'll have to rabies is 100% fatal disease. So no chances. The dose regulation is as per body weight. And the child at the age of 1 day and the person at the age of 100 years, the dose has to be calculated accordingly and should be administered accordingly. There is no problem in it.
It is the only life-saving.
Only thing. It is a fatal disease, na? That
Yes.
child we cannot take any risk. We'll have to give. There is no problem in it.
Thank you, sir. So
Welcome.
here we are concluding this session, and directly we are going to the next session. In the next session, we are inviting Dr. Dipendu Banerjee. Sir, please chair the
Good
session.
evening.
Yes.
Good evening. We are already running late, and
Yes,
I'd
sir.
request all our speakers to stick to the time limit. I know Partha will definitely do it. We've got a very interesting session on human papilloma virus, and we expect to hear something new, something innovative from our learned speakers. Our first speaker is Dr. Aruna Nigam, who will be speaking on WHO cervical cancer elimination strategy and the role of vaccines. Dr. Aruna Nigam is a professor and head, Department of Obs and Gynae, Hamdard Institute of Medical Sciences and Research, Oka, Delhi. Dr. Nigam, the virtual floor is yours.
Thank you, sir, for inviting me for giving this lecture, and especially Dr. Partha in the session in which Dr. Partha is there. So I will, without wasting my time, I will be starting with this lecture. The deliberation will be on WHO cervical cancer elimination strategy, role of HPV vaccine. So why we have chosen this? So you see, this is the statement in May 2018. I think I am not, okay.
Ma'am, if you don't mind, can you share the screen again, ma'am?
Okay.
Because we are unable to see the presentation.
Let me do it again. Is it visible?
Yeah, very much, ma'am. And I would request to put it on a slideshow.
Is it okay now?
Perfect, ma'am.
Thank you. Thank you. So, WHO cervical cancer elimination strategy, the role of HPV vaccine. You see, in 2018, WHO has given a statement that 1 woman dies of cervical cancer every 2 minutes, and each one is a tragedy, and we can prevent it. And this is the truth which we must always think of whenever we are talking of prevention of this disease. 9 in 10 cervical cancer deaths worldwide occurred in low and middle income countries, and women living with HIV are 6 times as likely to develop cervical cancer compared to women who are HIV negative. So the objective of the current deliberation is to tell you briefly about the WHO strategy to accelerate the elimination of cervical cancer, role of HPV vaccine, vaccine efficacy, immunogenicity, cross-reaction, recommendations on target age, dose, duration of protection, and queries in various situations. Why is a global strategy needed? Because cervical cancer is preventable disease and curable if detected early and treated appropriately. But it remains still one of the most common carcinoma and cause of cancer-related death in women across the globe. If you see this data, annual number of new cases of cancer cervix has been projected to increase from 5,70,000 to 7 lakhs between 2018 to 2030. And similar will be the increase in the number of deaths from cervical carcinoma as given by WHO. That will increase annually from 3.1 to 4 lakh approximately. And more than 85% of those affected are young, undereducated women living in LMICC with many mothers of young children. And if we are able to prevent this disease in these young women, we are able to save the families. So WHO in 2020 has given a strategy to accelerate the elimination of cervical cancer. And what was this strategy? 90, 70, and 90. That means we have to give a multi-pronged approach for the elimination of cervical cancer. So as a primary prevention, we need to vaccinate 90% of girls with HPV vaccine by the age of 15 years. 70% of the women should be screened with a high performance test by 35 years of age, and this should be repeated again by 45 years of age. And in tertiary prevention, 90% of women are identified with cervical disease, receive treatment, and 90% of the women with precancer should be treated. 90% of women with invasive cancer should be managed. And this is a 90-70-90 target given by WHO to achieve by 2030. So how much time we have? We have now 8 years, right? So why this 90-70-90 target has been given? Because to make a cervical cancer eliminated as a public health problem, we need to have a threshold of 4 per 1 lakh women years for elimination. And if we achieve this target, then we can decrease the median cervical cancer incidence rate by 42% by 2045 and by 97% by 2120. We can decrease the cervical cancer death 3 million by 2030 and 62 million by 2120. So there is a role of vaccine as a primary prevention, as you have seen. HPV vaccine is safe, effective, and well proven that it protects against the cervical cancer. But why are we focusing on HPV, human papilloma virus, and young girls especially? So you see, the primary cause of precancerous and cancerous cervical lesion is high-risk HPV. HPV 16 and 18 are the cause of 70% of the cervical carcinoma worldwide. It is the most common STI, and the pathogenesis of cervical cancer is same worldwide. So the high rates of cervical cancer incidence and mortality in low middle income countries is mainly attributed to lack of high quality screening and treatment. So here, if we are going to have a primary prevention, we can decrease this burden of screening as well as the treatment. But remember, you don't have to lose your screening or treatment simultaneously. So this should be a multi-pronged approach, and each and every component of this is important for the elimination of the cervical cancer. Why we have chosen this particular age? So if you see this graph, the incidence of HPV infection is mainly starting in a sexually naive population when they become a sexually active, and is maximum between 15 to 30 years of age group. And these HPV infection, when becomes persistent, lead to cervical cancer or having a pre-malignant lesion. So if we can decrease the HPV infection in this age group, we can have a decreased burden of these pre-malignant lesion after the age of 30 groups. And then these patients, if are screened appropriately, can lead to decrease in the incidence of the disease, early treatment of the disease. So that is the target, to have a sexually naive population to be vaccinated. There are many other reasons which I will be taking later on. So this is a well-proven fact that HPV vaccine is helpful in preventing the disease. I'm not going into the details of this trial, just to name a few: Future 1 trial, Future 2 trial, Patrica trial, Costa Rica trial, and many other studies. So if you see the Future 1, Future 2 trial, there have been 17,000 females between the 16 to 25 years of age and having a 3-year follow-up. And it has been observed that it has 100% efficacy against CIN2 and 3 and AIS, and 94% in preventing the anogenital and vaginal lesions after 3 doses and 3 years. Similar are the findings in the Patrica trial and the Costa Rica trial. So it has been clearly mentioned that it is efficacious. And this is the latest study by Drolet et al., published in Lancet, who have published previously also and done the systematic review and meta-analysis, and this updated systematic review, which they have done, and they stated that it includes the data from 60 million individuals and up to 8 years of post-vaccination follow-up. And their results showed the compelling evidence of the substantial impact of HPV vaccination program on HPV infections and CIN2 plus among girls and women, and on anogenital ward diagnosis among girls, women, boys, and men. So it is clear that HPV vaccination have to be done, and we have to focus on this age group. Regarding the immunogenicity of this vaccine, it is highly immunogenic with a seroconversion rate of 93 to 100% following bivalent or a quadrivalent HPV vaccination, and antibody levels 1 to 4 logs higher concentration than the levels generated due to natural HPV infection. Both vaccines have demonstrated high efficacy lasting for at least 10 years and significantly higher antibody titers as compared to natural infection. Are we having a cross protection? Because we just said that 16 and 18 are the cause of cervical cancer in around 70% of the cases. So yes, cross protection have been proven against HPV 31 and 45 with a bivalent vaccine efficacy in 54 and 88% respectively. The quadrivalent vaccine reduced the incidence of HPV 31 and 45 infection by 40% and CIN1 plus AIS by 43%. Efficacy against CIN2 plus and AIS associated with 10 non-vaccine oncogenic time was found to be 33%. So we have a cross protection also by either giving bivalent or a quadrivalent vaccine. What should be the target age group? Yes, as you can see, we should be focusing on the school age group. So it is recommended by WHO, GOI, Indian Academy of Pediatrics, FOXI, and all the societies that to end the cervical cancer, we need to have 9 out of 10 girls should be vaccinated in HPV, and the primary target age group should be adolescent girl, that is between 9 to 14 years. But that doesn't mean you cannot vaccinate the higher age group. But your primary age should be to vaccinate at least this group 100%. So the target age group regarding other age groups, vaccination of older females should be considered only if it is affordable, cost effective, and does not divert resources from vaccinating the primary target population or screening for cervical cancer. Geometric mean titer induced by both the vaccines are 2 times higher in a sexually naive population that is less than 15 years than the girls aged 16 to 26 years. And ACIP recommends catch-up HPV vaccination, and this is the strategy this have been taken already by the Australia, US for all persons through age 26 years who are not adequately vaccinated. However, the decision to vaccinate adults older than 26 years should be made on an individual basis. What are the types of HPV vaccine available? So we have a Cervarix, we have a quadrivalent Gardasil, and now we have also availability in India of a monovalent vaccine also. Currently, we are not having free availability of Cervarix. I think Dr. Partha can tell us regarding this availability, because now practically we are finding that Cervarix is nowhere in the market. Only we are getting for a subsequent immunization if it is due. So type of HPV vaccine, we have 3, as I told you. So bivalent, if it is protecting against 16 and 18, but we have a cross protection against 31 and 45. Gardasil is freely available, quadrivalent vaccine. 16 and 18 and 6 and 11 are the viruses against which it protects. 6 and 11 are responsible for the warts, and the nonavalent vaccine, which protect against 16, 18, 6, 11, 31, 33, 45, 52, 58. Here, I would like to tell you the cost, which I have not separately included. Bivalent is around 2,500, quadrivalent is around 3,100 to 3,500, and nonavalent is still not very cost effective. It is 9,000 to 10,000 per dosing. So we have to think with which vaccine we have to vaccinate. Regarding the dosage schedule, and this is the newer thing which has come, and Dr. Partha is going to take on it, and I'll not touch upon it. So just a FOXI recommendation from my side, which are in the process of change also. So, but the number of doses for girls less than 8 less than 15 years is currently 2 doses. Number of doses for girls more than 15 years or if they are HIV infected are 3 doses. And interval between the 2 doses is around 6 months. And I'll tell you, if you forget to give or the patient forget to take, I'll take that also. Catch-up vaccination can be done between the age of 15 to 26 years with 3 doses, and older age group can more than 26 years have to be given 3 doses. But there are this concept has to be kept in mind that you cannot say that you don't have to go for a screening. Each and every patient and every female have to go with the screening above the age of 26 years. And this is screening, if you are done doing with HPV DNA testing, should start at the age of 30 years. So this is the topic being taken, recent one, that 1 dose is effective by Dr. Partha. So now regarding the booster shot, there is strict no, we don't have any data regarding it, and currently it is not recommended because the protection and the persistent antibody levels have been observed through a minimum of 10 years following vaccination among female participants against high-grade cervical, vaginal, and vulvar neoplasia. What is the safety? No serious events have been reported. Only a minor events like a pain at the vaccination site, tenderness, swelling, fever, headache, myalgia, or gastrointestinal symptoms have been reported. And reported rate of anaphylactic reaction is 1.7 cases per million doses. Remember, this is the data from all over the world, and where the 270 million doses have already been provided globally. So what are the contraindications? If you have hypersensitivity to any of the vaccine components, right? History of hypersensitivity to yeast, person with a latest allergy should not receive bivalent HPV vaccine. And in case of an allergic reaction such as itching, rash, urticaria, or blisters occurring post-HPV vaccination, further doses should not be given. Avoid vaccination in girls with severe febrile illness. Oh God, if you forgot the dose, so what is the criteria or what is the recommended on interrupted dose schedules? So there is no need to restart. Only the remaining doses should be administered when the recipient is willing to complete the schedule. Better antibody response has been reported in studies where there is a longer interval between the 2 doses than shorter interval. Co-administration with other vaccines, this can be a very good strategy, beneficial as it may increase the chance of receiving vaccine on schedule and will reduce the number of visits to the healthcare center and can be safely administered along with other age-specific vaccines. Just talk about the special population. If you receive a patient with a sexual assault, what should be your take? So sexual assault increases the risk of HPV infection. Although vaccination does not help in virus clearance, remember this, or protection against the already acquired infection, but does provide protection against infection not yet acquired. So the recommendation is that it should be advised a 3-dose course of HPV vaccine with first dose at the time of initial examination. Women with abnormal pap smear, very common situation we deal in day-to-day practice, positive HPV test or previous HPV lesions. So HPV vaccination in women previously infected with HPV is safe. Lead to high level of immune response evident by the presence of potentially neutralizing anti-HPV antibodies in cervical vaginal secretions. Protection against non-prevalent HPV types included in vaccine is activated similar to that in HPV-naive women. But remember that when we are doing a pap smear above the age of 21, 25, 26, or 30, so you cannot go for without screening. So screening has to continue in a similar manner. Repeatedly, I am quoting this. So what about the pregnancy and lactation? It is not recommended during pregnancy. However, termination of pregnancy is not required if a woman becomes pregnant during the vaccination schedule, and the remaining dose of the vaccine should be withheld and give 6 weeks post-delivery. It is not contraindicated in lactation. Immunocompromised
Madam,
women.
we should end now.
Yes, it is
Where-
2 slides more only. Immunocompromised women, particularly transplant recipient and HIV-infected women, are at high risk for HPV-related disease and should be vaccinated with 3 doses of HPV vaccine. Male vaccination. Male vaccination has been licensed in US in 2009 and subsequently in many other countries like USA, Canada, and now UK also is doing this. So they can be vaccinated because it protects against anogenital warts in addition to protecting against anal, penile, and oropharyngeal carcinoma. So it is recommended for 11 to 21 years boys and can be given up to 26 years for the prevention of genital warts and anal carcinoma, and can also be given up to the age of 26 years in men who have a sexual intercourse with the men. Male vaccination with HPV vaccine has been introduced in countries where optimal vaccination has already been achieved in the girls. So to conclude, incorporation of HPV vaccination in the prevention of cervical cancer is the need of our. Only single dose can be effective. Combining vaccination with screening will bring about the most rapid decline in the incidence of the cervical cancer. Thank you all for your patient hearing.
Thank you, Dr. Nigam, for your illustrative talk comparing the bivalent, the quadrivalent, and the new monovalent vaccines. Without wasting time, we would move on to our star speaker, Dr. Partho Basu, who will be talking on evaluating a single dose of HPV vaccine. Dr. Basu is an MD in gynecology and PhD in clinical oncology. He was trained as a gynecological oncologist in the Imperial College of London. He's presently the acting head of Cancer Early Detection and Prevention Branch at International Agency for Research on Cancer, which is a specialized cancer agency of WHO. Dr. Basu has 202 peer-reviewed publications with more than 5,000 citations. It's a pleasure to introduce you, Partho. The floor is yours.
Thank you so much, Dibyendu. It's nice to meet you virtually after so many years. Let me share my screen.
Yeah.
Is it okay?
Fine.
Right. Good evening, everyone. In the excellent talk by Dr. Aruna, she has already explained that there are 3 vaccines in the market, and the standard dose regimen for these vaccines is below 15 years of age, 2 doses, and above 15 years of age, 3 doses. But then only 2 weeks back, the WHO came out with this new recommendation, which says 1 dose of HPV vaccine offers solid protection against cervical cancer. And what is its implication? Its implication is huge. As Dr. Aruna again very nicely explained, cervical cancer is a major public health problem for the low and middle income countries, where we see 90% of the deaths from the cancer occurring. But the unfortunate fact is that when it comes to access to the vaccine, we see, if you look at this map, which is showing the countries that have HPV vaccine in their national immunization program. These are all high-income countries: North America, Europe, Australia. Latin American countries, of course, did quite well in terms of introduction of the vaccine. But look at Africa, look at India, China, the countries that are contributing to the largest number of cervical cancer. They do not have the vaccine in their national immunization program. And what is the reason? The reason is the high cost of the vaccine. In fact, this is the costliest vaccine to be introduced in the national immunization program in any country. Just to give you an idea, the lowest price of the vaccine that has been worked out by the Gavi Alliance is $4.5 per dose. So if it is $2 per adolescent girl, so the vaccine procurement cost itself comes to $9. And it has been estimated that to provide two doses of the vaccine, we need to spend another $7 to $8 per girl for rolling out the vaccine. So the cost per girl vaccinated comes to around $18 to $19. And you know what is the total cost of administering 9 doses of the vaccine that are given in India? It is $30. So if we go and tell the health minister that we have to add another vaccine that is going to cost $18 per dose, obviously they are going to be very, very hesitant. And that is the reason why at the present moment, less than 20% of the girls in the world, they have received the vaccine. And we are talking about 90% coverage. So that is the problem number one. Problem number two is, whenever there is a vaccine that requires 2 doses to be administered, keep track of these girls, making sure that the girls who have received first dose, they get the second dose, is a huge challenge for the low and middle income countries. Look at this particular graph. This graph is showing the HPV vaccine coverage in the low and middle income countries that could afford to introduce the vaccine. The yellow dots, those are showing the coverage for the first dose. And you can see in most of the LMICs, the coverage for the first dose is, above 70%. But for the same countries, when it comes to the second dose coverage, which is shown by the blue dots, from 98%, it is coming down to 39%, 40%. You can see across all the different countries. So for the low and middle income countries, providing 2 doses of a vaccine itself is a challenge. So that is the challenge number 2. And the challenge number 3 is the short supply of the vaccine. As Dr. Aruna said, the GSK, because of certain reason, they have stopped production of the vaccine. And there isn't enough vaccine in the market to give it to the lower and middle income countries. And that's why many of the countries are not being able to introduce the vaccine, even if they can afford. So now think of all these 3 challenges. If there is one solution, that is, if we can move from 2 doses or 3 doses to a single dose. Now, is it possible? I was listening to the rabies story and the rabies vaccine story. And over time, the vaccine type changed. But here we are not talking about changing the type of vaccine, not changing the constituents of the vaccine. Whether the same vaccine will work if we give single dose of the vaccine. Now, the very first indication came from this trial, which is Costa Rica vaccine trial. It was just another randomized controlled trial to evaluate the bivalent vaccine or Cervarix vaccine in 18 to 25-year-old women. Just like any randomized trial, there was a group that received the HPV vaccine. They received 3 doses of the vaccine. That was the protocol. And there was a control arm that received only hepatitis A vaccine. Now, in the trial, there were some participants who were non-compliant. So they received either 2 doses of the vaccine and some received only a single dose of the vaccine. When they evaluated the performance of single dose of the vaccine and compared that to 2 doses or 3 doses, as you can see here, the efficacy against persistent HPV 16 and 18 infection was exactly comparable. But then in this trial, the number of girls or women who received a single dose was very few. You can see less than 200 that received HPV vaccine single dose. Now I'll tell you the story of the study that in the International Agency for Research on Cancer, where I work, that did and is still continuing. So this study is started in September 2009 as a randomized controlled trial to compare 2 versus 3 doses of the quadrivalent vaccine. Remember, that time the standard recommendation was to give 3 doses of the vaccine. So we wanted to see how 2 doses of the vaccine will work if we target 10 to 18-year-old unmarried girls in India. So the plan was to have 20,000 10 to 18-year-old girls randomly allocated either to receive 2 doses of the vaccine at 0 and 6 months or to receive 3 doses of the vaccine at 0, 2 and 6 months. So the recruitment was going on fine. But by the time, we had recruited nearly 90% of the participants. On 8th of April 2010, the Ministry of Health, they came out with an order that henceforth no vaccination would be allowed in any trial. And some of you may remember that it was because of some study that was going on in Gujarat and Andhra Pradesh using the vaccine, and there were a few deaths, nothing to do with the vaccine. Some of the deaths were like fall in open well, snake bites, insecticide poisoning, but a hue and cry was created, and then the ministry said no more vaccination in any trial. Now, because of this abrupt stoppage of vaccination, we landed up with a situation where some girls, they received 3 doses of the vaccine per protocol. Some received 2 doses per protocol. Some received 2 doses at 0 and 2 months. And some girls received a single dose of the vaccine. And if you look at the number, they are almost evenly poised. And that gave us an unique opportunity to evaluate single dose of the HPV vaccine, which at that point of time, no ethics committee would have allowed us to do. Now, what are we doing with, now these girls, we stopped vaccination, but we kept them under follow-up. Over the last 10 years, we are systematically following up all these girls. Now, most of them are women every year. So each year they come, we ask them about any serious adverse event that has happened. We just do a health checkup. Once they get married, and 18 months after marriage, we start collecting cervical cells to look for HPV, presence of HPV and genotyping that HPV. We use a very sensitive HPV genotyping test that is called Luminex assay that looks for 21 HPV types. So once they start providing the sample, the sample is collected yearly for 4 consecutive years. Why do we do that? Because for HPV virus to cause cervical cancer, persistent infection is the most important thing. One-time infection does not mean anything. And to prove persistent infection, we have to serially check these women. So that is why every year, these married women, they are providing cervical sample, and then we are collecting 4 such samples. And as you can see in our study, there were no unvaccinated controls. So we added a group of unvaccinated age-matched women, and these women are also providing cervical samples that will allow us to estimate the protection against persistent infection. Now, as you know, there are 2 ways any vaccine is evaluated. We look for the antibody response. So yes, we collected blood samples at baseline and at different time points from these vaccinated girls. And on the left-hand side in the graph, you can see the total antibody response against HPV-16 by the dose groups. The 2-dose and 3-dose group, the antibody response is exactly overlapping each other, which essentially shows that there is no difference in antibody response in the girls if you give 2 doses or 3 doses. In fact, this data was instrumental in the WHO recommendation when they said girls younger than 15 years, they do not require 3 doses, they can get 2 doses. This is same for 16 as well as for HPV-18. Now, what happens to the single dose recipients? You can see the single dose recipients definitely had an inferior response as compared to the 2 doses or 3 doses, 3 dose recipients. But then what is very interesting with this particular vaccine is you don't need a large amount of antibody. Why is that so? What in this picture, in this cartoon, what you are looking at is the epithelium of the cervix. Yes, the cervix has multiple layers of cells in the epithelium. And this virus needs some break in the epithelium and go down and infect the most basal or the lowest level of the cells. It has to get inside the cell, then only it can replicate itself within the cell and cause the neoplastic changes. Now, once the virus infects, to get inside the cell, it has to undergo certain conformational changes, and that takes quite a few hours. Now, whenever there is a break like this is a wound. And it's because it's a wound, there is always an exudation, and that exudate contains the IgG antibody induced by the vaccine. And that little amount of IgG antibody can neutralize these viruses because there is enough time to neutralize them. And that is the reason a very small amount of antibody can be effective. And this has been proved by animal studies, mechanistic studies, and even our study has proved that a little amount of antibody will give the protection. Now, for public health perspective, always the concern is, fine, I may have antibody response, but how long is that antibody going to protect? So now, as our cohorts have reached 10 years, we have looked at the antibody response at 10 years. Now here we have looked at the antibody response again. You can see that this upper curve is 3-dose arm, which is obviously much higher as compared to the single dose arm. But what is most important in the single dose arm is that you can see there was the antibody went up, and then over the last 10 years, it is remaining at a sustained level. There is no dip in the antibody titer either against HPV 16 or 18, 6 or 11. In fact, nearly 100% of the girls who received the vaccine, they're still seropositive at 10 years post-vaccination. And again, what is the explanation for that? The explanation lies in the specific nature of the antibody, nature of the vaccine. This vaccine has virus-like particles as the antigens, and the virus-like particles are actually, these are L1 surface protein of the virus. Now, as these L1 surface proteins are artificially produced in any production system, they take the form of the virus. It looks exactly like the virus. And as you can see on each VLP, this is called virus-like particle. On each VLP, there are a few hundred of L1 proteins. So each L1 protein acts as an antigenic stimulus. So with a single VLP, there is a multiplication of the antigenic stimulus, and this creates a robust stimulation of the long-lasting memory B cells. And as immunologists, all of you know that these long-lasting B cells which reside in the bone marrow, they keep on secreting antibody over many, many years. And that is the reason why this virus is producing the antibody for over so many years. Fine. So that is the story of antibody response. What is the story? What happens to the protection against persistent infection? As I said, it is the virus has to protect against persistent infection. Incident HPV infection is not important. We have to show that the virus is protecting against HPV 16 and HPV 18 infection, because these two viruses cause about 75 to 80% of cervical cancers. Now look at our own data. So now at the present moment, we have 1,268 unvaccinated participants who have been assessed for persistent infection. And among them, we find 2.7% of them have persistent HPV 16 and 18 infection. As compared to that, all vaccinated, we have 5,788 vaccinated women evaluated. It is 0.1%. That means 27 times lower. And what is most important is, if you look at the percentage in 3-dose arm, 2-dose arm, and a single dose arm, it is exactly the same, almost zero persistent HPV infection. I'm not going into the story of cross protection. The cross protection of Gardasil is relatively less, but still we are seeing some amount of cross protection. And what is important is the cross protection being offered by a single dose is exactly the same as 2 doses or 3 doses, because we are seeing the same proportion of persistent infection with these types. So with this, we could estimate the vaccine efficacy. Now, let us look at the vaccine efficacy of 3 doses against HPV 16 and 18 persistent infection endpoint, 91.2%. With 2 doses, 94.5%. With single dose, 94.2%. And look at the confidence interval, it is quite narrow. That tells us that this difference is quite significant. And we can also see comparative efficacy against the cross-protective infections, though the confidence interval is quite wide because we still don't have adequate number of cross-protection infections from these types. Now, you may ask, okay, the IARC study has shown protection against persistent infection, but what is the protection against the real disease? What do you call precancers, high-grade precancers called CIN2, CIN3 or cancer? Now, as you know, Australia is the country that introduced the vaccine first way back in 2007. And many of the vaccine recipients, they have now started being screened. And because they have excellent vaccine registry and excellent screening registry, they can link up these 2 registries and can find out what happened to the vaccinated women in terms of their development of CIN2 or worse disease and what happened to the unvaccinated women. So this is the data. There are nearly 50,000 unvaccinated women, and among them 7.6 per thousand women years there were CIN2 or worse lesion in development. So if we take this as 1 for hazard ratio estimation as the standard, as compared to that, the 3-dose recipients, they had 40% lower incidence of CIN2 or worse disease. 2-dose recipients had 40% lower incidence of CIN2 or worse disease, and single-dose recipients also had 35% reduction in CIN2 worse disease. And this is the data coming from the real life programs, not from any study. So now, as Dr. Nigam said, that India is a signatory to the World Health Assembly declaration that we will be eliminating cervical cancer. In spite of our NTAGI recommending this vaccine, we have not yet been able to introduce the vaccine. Hopefully, the single dose recommendation will change the scenario and we will be relieved of the dubious distinction of providing the largest number of cervical cancer to the world, which is more than 100,000 women every year. I'll stop my presentation by thanking the excellent collaborators that we have all across India. Thank you very much. Dibendra, I think you are muted.
Yeah, sorry. Thank you, Partho, for your excellent deliberation. Well, the single-dose vaccine does hold a lot for us in future, maybe in our country, especially in a country like ours, which is developing. I wouldn't say India is a poor country now. It's a developing country. And indeed, if these studies takes us forward, it holds a lot of promise for the younger generation of our country. Our next speaker would be Dr. Shamima Yasmin, and she'll be talking on pregnancy and the need for immunization. Dr. Shamima Yasmin is the Assistant Professor of Community Medicine, Medical College, Kolkata. She is a postgraduate teacher and an MBBS examiner with 10 years of experience. She's an assistant managing editor of the Journal of Comprehensive Health, Journal of West Bengal State Chapter, Indian Association of Preventive and Social Medicine. She's a state-level trainer of MA, IYCF, IMNCI, NIPI, ICDF. She has 20 national and international publications. Welcome, Dr. Shamima Yasmin.
Thank you so much, sir. Today's presentation is on pregnancy, the need of immunization. Let me share my screen. So is it visible?
Yes,
so is it visible? My screen?
Yes, ma'am, it is visible, ma'am. Please continue.
Okay. Today's presentation, pregnancy, need for immunization, a very important topic, as we find that usually the pregnant women are very hesitant about, there's a lot of vaccine hesitancy among them, not only about the mothers, but also healthcare providers. There's a lot of indecisiveness as to be giving the vaccines among them. So 1 second. So we see that there is a lot of vaccine hesitancy among the pregnant mothers, as well as among indecisiveness among the healthcare providers. But we should remember that vaccination is something that gives a clear dividend, and for pregnant mothers, it is twice. A mother shares everything with her baby. That means when we are vaccinating mothers, we are not only protecting her, but also giving the baby some early protections too. Immunization is a key component of primary healthcare and an indispensable human right. So how can we deprive this vulnerable population of pregnant women? So they has to be given, and we need solid evidence-based guidelines for immunization in pregnancy. Vaccines are also critical for prevention and control of infectious disease outbreak. So as we see in the last 2 years of pandemic, that initially there were a lot of apprehensions about vaccinating pregnant women, but ultimately we got our recommendations and pregnant women were vaccinated by COVID vaccines. Regarding the guidelines, for special situation, for special population, we have the Advisory Committee of Immunization Practices, the ACIP guidelines that is followed, which gives us the guidance for vaccine recommendations in pregnant and breastfeeding women. They say that benefits of vaccinating pregnant women usually outweighs potential risk when the likelihood of disease exposure is high, when infection would pose a risk to the mother or fetus, and when the vaccine is unlikely to cause harm. So we always have to weigh the benefits against the risks. The ACIP guidelines that were given in 2008, first time, they regularly update their guidelines, but the initial guideline also is valid till today. Their basic guidelines are: there is no evidence exists of risk to fetus from vaccinating pregnant women with inactivated virus or bacterial vaccines or toxoids. There are some problems with the live vaccines. Live vaccine administered to a pregnant woman pose a theoretical risk to the fetus. Therefore, live attenuated virus and live bacterial vaccines are generally contraindicated during pregnancy. If you follow the Center for Disease Control and Prevention, the CDC guideline, they recommend that vaccination among the pregnant women should be planned according to their age, lifestyle, medical condition, their travel, or previous vaccination status. Usually, they recommend 2 vaccinations that is to be given to every pregnant woman: the inactivated flu vaccine and the inactivated flu vaccine and the Tdap vaccine, the tetanus, diphtheria, and the acellular pertussis vaccine. CDC also recommends the COVID-19 vaccination for the pregnant women now. The American College of Obstetrician and Gynecologists recommendation, the ACOG recommendation, also recommends tetanus toxoid, reduced diphtheria toxoid, and the acellular pertussis vaccine. Now let's come to India. According to the National Immunization Schedule and according to a national program, RMNCAHNN, it says the only vaccine that is recommended, that are given free of cost to all pregnant women, are the TD vaccines. As we all know, earlier the TT vaccines were given, which were changed by the NTAGI recommendation in 2016 and 17, that it was changed to the TD vaccine, where the diphtheria component was added. 2 doses of TD is recommended in the pregnancy. First dose as early in pregnancy, first time when the mother comes, and the second dose is given after a 4-week. They are given intramuscularly 0.5 ml in the upper arm. And if the mother has a pregnancy within 3 years, then only 1 TD booster dose is given. Usually the recommendation is the dose should be completed within 36 weeks of pregnancy. And if by chance the mother comes to the healthcare center after 36 weeks of pregnancy, we give the, we usually say it is to be completed within 36, but if they come for the first time, we do give the vaccine. We tell the mother that there might be risks. So other methods of prevention of neonatal tetanus has to be followed, like institutional delivery, but we do not deprive the mother the vaccine. The recommendation is the vaccine has to be given. Also from the government level on the national program, the COVID-19 vaccination is to be given as per the NTAG recommendation. A pregnant woman who opts for vaccination should be vaccinated at any time of the pregnancy. To help pregnant women make an informed decision, the healthcare provider should help the mother to take the decision. They should be told about the various risks of COVID-19 infection in the pregnancy, along with the likely side effects that can occur. Coming to the individual vaccines, as we said, the various recommendation, the national recommendation, as well as the worldwide recommendations, the tetanus, diphtheria, and pertussis vaccine are to be given. The health personnel should administer a dose of Tdap on early pregnancy, irrespective of the patient's prior history of receiving Tdap. The optimal time gap is to be given between 27 to 36 weeks window. If Tdap is not administered during pregnancy, Tdap should be administered immediately postpartum. Obviously, the mother should be informed about the risk involved. The next vaccine, we're talking about the acellular pertussis or whooping cough vaccine, as we say, another name for pertussis. It has been seen that there are a lot of newborn deaths due to pertussis, and hence this acellular component was added. Whooping cough is a life-threatening disease. The younger the child, the more the problem. It leads to a lot of hospitalization, and it can lead to a life-threatening situation. So this acellular component added to the mother will affect the child by transfer of the passive antibody. Also, it is very difficult to diagnose the whooping cough among the small children, as there is no cough. They suddenly stop breathing and turn blue. So this is a matter of concern. So to prevent this, to maximize this passive transfer of antibody, this acellular component has been added to Tdap. Another thing that needs is for the prevention of pertussis, that is cocooning. So not only the mother, even all the health provider who are around the child, like the family members or who is the nanny who is looking at the child, it is recommended the cocoon strategy or a ring of immunization among them, so that they could be prevented from pertussis by giving Tdap to these family members. They has to be given at least 2 weeks before they come in contact with the newborn child. Coming to the next vaccine, that is the flu vaccine. CDC recommends getting the flu vaccine for pregnant mothers during the flu season. While the flu season vary in the timing, CDC recommends the vaccination by the end of October. Getting flu vaccine during pregnancy is one of the ways to protect mothers and their babies for several complications that arises due to flu. Actually, influenza vaccination for pregnant women is especially needed, as pregnant women are at risk of maternal morbidity and mortality. Also, the fetal morbidity increases if the mother suffers from flu. It can lead to congenital anomalies, spontaneous abortion, and preterm birth. Another important vaccine, we have heard a lot from the Shumit sir and Boishaki about the rabies vaccine. But what about rabies vaccine in pregnancy? As we know, rabies is a disease that is 100% fatal. So we just cannot deny the post-exposure prophylaxis for the pregnant mother. If a pregnant mother is bitten by a stray dog, it needs proper post-exposure management. Vaccination is not contraindicated in pregnancy and breastfeeding. We have to give the anti-rabies vaccination to them. In fact, a study that was shown in the NLM library, everybody can search for it. It says it's a systemic review where it says that there were deaths of pregnant women due to the vaccine hesitancy. There were incidents of dog bite, and they had not taken the vaccine because of their pregnancy status. They were very apprehensive about the vaccine risk factors, and it had led to death of 6 pregnant and breastfeeding women in the year 2015 and 16 just because of vaccine hesitancy. So a lot of awareness is needed. Mothers as well as healthcare providers should be trained about the contraindication and when the risks are more than the risks are more, we need to give a vaccination. It has been seen that awareness is mostly to be given by the obstetric care providers. If the obstetrician helps the mother make this decision, it has seen that the acceptance is 5-fold to 50-fold more. The other vaccines that are under consideration for pregnant mothers are, for example, hepatitis A. The safety of hepatitis A vaccination pregnancy has not been determined. It has been seen that if the risk is small, then hepatitis A vaccine can be given. The risk associated with vaccination should be weighed against the benefit. And if the mother is at risk of exposure to hepatitis A virus, they has to be given the vaccine. Next, come to hepatitis B vaccine. Pregnancy is not a contraindication. So if vaccine is needed, they have to be given. If a pregnant mother is exposed to a partner who is HBs antigen positive, or there are more than one sexual partners, they have to be evaluated and they have to be given hepatitis B vaccination. Since hepatitis B vaccination comes from non-infectious surface antigen, HBs antigen, there is not much contraindication to the vaccination. Next, coming to HPV, we have learned a lot from Aruna ma'am and Pasteur about the human papilloma virus, but what about the pregnancy? In pregnant state, it is usually not recommended. But what is to be done if the mother has already started the first dose and then she comes to know about the pregnancy? We usually stop the remainder doses and it is to be delayed till the completion of pregnancy. Usually, pregnancy testing is not required before the vaccination, but if the vaccine was administered by chance during pregnancy, it is not an indication for abortion. They can continue the pregnancy. Next, coming to the MMR vaccine, the measles, mumps, and rubella vaccination. MMR vaccine is not to be administered to women known to be pregnant or they wish to be pregnant. Women should be counseled to avoid becoming pregnant after 28 days of receipt of vaccination. If vaccine is inadvertently administered to the pregnant women within the 28 days of vaccination, she should be counseled about the theoretical risk it can offer. Rubella susceptible women who are not vaccinated should be told about the congenital rubella syndrome and importance of vaccination, and they also should be vaccinated after the pregnancy is over. About the other vaccines, meningococcal vaccine, more RCT has been conducted as far as to evaluate the use of meningococcal vaccine. Vaccination should be deferred in pregnancy and lactating mother unless the woman is in high risk. Pneumococcal conjugate is, there is not much recommendation about it, but the safety of pneumococcal polysaccharide can be given in the second and third trimester. There's some risk for in the first trimester. As regards to polio, there is no adverse effect of IPV as it has been documented, but this here also we have to weigh the risk, and if it is required, it can be given. The yellow fever vaccination, there's a lot of controversy regarding the yellow fever vaccination for pregnant mothers will be traveling. It has been said that according to ACIP recommendation that it is a precaution. It's a precaution for the yellow fever vaccination compared to contraindicated of other live vaccine. If travel is unavoidable and risk of yellow fever exposure are felt to outweigh the vaccination risk, a pregnant woman should be vaccinated. If the risk of vaccination felt to outweigh the risk of yellow fever vaccine, pregnant women should be issued a medical waiver to fulfill the international health regulation. Because pregnancy might affect the immunological function, if it is by chance given in pregnancy, it has to be serological testing has to be done later to find the immune response. Although no specific data are available, a woman should wait for it after receiving yellow fever vaccine before conceiving. The general recommendation on immunization by Advisory Committee 2011 states that there is no risk for fetal from passive immunoglobulin transfer to pregnant women, so it can be easily given. So, if we can summarize the various vaccine, hepatitis A, we have to weigh the benefit against risk. It can be given. Hepatitis B is recommended in some situation. HPV is not recommended. Influenza, the inactivated one, is recommended. The live attenuated one is contraindicated. MMR vaccine is contraindicated. Meningococcal the ACWY varieties can be used if otherwise indicated. Meningococcal B, we have to weigh the benefits against risk. Polio may be used if needed. TD is recommended, as we know it's in the national immunization schedule itself. For the private sectors, Tdap is given. It is the recommendation by CDC. The Tdap is usually preferred. The varicella is contraindicated. The zoster vaccine is also contraindicated, and the pneumococcus is given only if there is high risk. If there is travel in pregnancy, the general recommendation for use is anthrax. If there is a low risk of exposure, it is not recommended. It is only given if there is a high risk of exposure. BCG is contraindicated. Japanese encephalitis, there's inadequate data for specific recommendation, but yes, if there is a high risk, it can be given. Rabies, as we said, should definitely be given if required, if there is a exposure by bite. Typhoid, there is an influenza data that is not adequate, but if given, the VI polysaccharides will be given. Yellow fever can be used if you weigh the risk against benefit. Regarding Zika vaccination, the vaccination is in development, so we recommend the mosquito protection and other various protections for prevention of Zika. Vaccines, so if we summarize, the vaccines that are not recommended during pregnancies, which we have to take special care, are the things that has to be remembered is we cannot give the HPV vaccine, the MMR vaccine, the live influenza vaccine, and the varicella vaccine. Certain travel vaccine, as I said, yellow fever, typhoid fever, and Japanese encephalitis, there has to be, the risk and benefit has to be weighed, and the healthcare provider determines which should be done. So summarize in a whole, we know that inactivated viral, bacterial, and toxic vaccine cannot be used can be used in pregnancy. The most common reactions are local erythema and swelling. If a woman receives a live or live attenuated vaccine, she should be counseled to, and she should not be counseled to terminate the pregnancy, as there is no teratogenic risk. Live vaccine in pregnancy is only present in theoretical cases. They are not contraindicated, but if a woman receives, they have to wait for 4 weeks. It has been seen that around in a study that 304 women were exposed to yellow fever vaccination, and there was no major fetal malformation. If a pregnant woman receives a live or live attenuated vaccine, they should delay pregnancy for 4 weeks. Household contents can safely be vaccinated, and in fact, they should be vaccinated to promote a cocoon immunization effect similar to the immunity. Thank you.
Thank you all the speakers and chairperson. Probably Dr. Dipendu sir is having some technological problem. He is not here. We are very much thankful to Dr. Aruna Nigam, Dr. Parthu Basu, and Dr. Samima Yasmin for very informative session. And now we have an announcement that in the hall B, we have started with the panel discussion. You can join in the hall B. Here we are concluding this session. Thank you.
Started with this, that is a live, which is about the
Jignesh.
the children and also some of the adults.
Jignesh